Muscle activity to attain or maintain the standing posture. Every time the examiner tries to let it take weight on his feet, he collapses into flexion.
শুভ সকাল। ফার্স্ট ন্যাশনাল কনফারেন্স অন ডাউন সিনড্রোম 2016-তে আগত সকল সম্মানিত অতিথিবৃন্দকে জানাই শুভেচ্ছা ও স্বাগত। সম্মানিত অতিথি, আসসালামু আলাইকুম। বাংলাদেশ ডাউন সিনড্রোম অ্যাসোসিয়েশন প্রথমবারের মতো বাংলাদেশে জাতীয়ভাবে এই কনফারেন্সের আয়োজন করেছে। হাঁটি হাঁটি পা পা করে বাংলাদেশ ডাউন সিনড্রোম অ্যাসোসিয়েশন আজ 3 বছরের শিশু। সমগ্র বিশ্বের 11তম ও বাংলাদেশের তৃতীয়বারের মতো 21শে মার্চ এই দিবসটি পালন হচ্ছে। বাংলাদেশ ডাউন সিনড্রোম অ্যাসোসিয়েশন ডাউন সিনড্রোমের শিশুদের মাঝে লুকায়িত সুপ্ত প্রতিভাকে কাজে লাগিয়ে তাদেরকে সমাজের মূল স্রোতধারে নিয়ে আসার প্রত্যয় নিয়ে গত 2014 সাল থেকে তাদের যাত্রা শুরু করে। এই যাত্রাপথে বাংলাদেশ ডাউন সিনড্রোম অ্যাসোসিয়েশন ডাউন সিনড্রোমের শিশুদের সর্বাধুনিক চিকিৎসা সেবা প্রদানের পাশাপাশি বিভিন্ন জনসচেতনতামূলক কার্যক্রম পরিচালনা করে আসছে। আর তারই ধারাবাহিকতায় আমাদের আজকের এই আয়োজন। আমাদের এই শিশু বিশেষ শিশু, সে এই জগতের অন্যায় অপবাদ হিংসা বিদ্বেষের উদ্ভিদ। তার মন আছে, অভিমান আছে, কিন্তু হীনমমতা নেই। এই ডাউন সিনড্রোম শিশুদের নিয়ে আমাদের আজকের আয়োজন ফার্স্ট ন্যাশনাল কনফারেন্স অন দ্য ডাউন সিনড্রোম। শুরুতে ইনঅগুরাল সেশন, এরপরে আছে সায়েন্টিফিক সেশন। আমাদের এবছরের কনফারেন্সের প্রতিপাদ্য বিষয় My friends, my community, the benefit of inclusive environment for today's children and tomorrow's adults. আমার বন্ধু, আমার কমিউনিটি, একটি পরিবেশ আজকে শিশু ও আগামী দিনের পরিণত মানবের সুফল। এই প্রতিপাদ্যকে সামনে রেখে আমাদের আজকে first is time for conversation. This session will be chaired by Professor Misbah-Uddin Ahmed, President of Bangladesh Down Syndrome Association. We are proud and honored that today we have Dr. Indus Ali Sarkar, Honorable MP and member of the Parliamentary Standing Committee on Health, with us as our chief guest. And today, we have Professor Sophia Khatun, Professor of Pediatrics, Center for Women Child Health Suffer, Dr. Mohammad Shahadat Hussain, Vice Principal Sheikh Sawardi Medical College Hospital, Jawahirul Islam Mahmood, Maharashtra Sweet Bangladesh. And Dr. Ajunta Rani Shaha, Secretary General of Bangladesh Down Syndrome Association, is also with us, whose inspiration, motivation, and dedication made us together today on this conference. Now, I request Professor Misbah-Uddin Ahmed, President of Bangladesh Down Syndrome Association, to accompany our special guest to come along the stage with our honorable guest. I request Dr. Ajunta Rani Shaha and Dr. Misbah-Uddin Ahmed to please accompany our today's guest over the stage. Professor Shahid Hussain is also here and she is the Vice Principal Sales Services Medical College. It's mentioned that our principal Professor A.B.M. Masudul Ansar could not be present here today due to some unavailable circumstances. এখন পবিত্র কোরআন থেকে তিলাওয়াত আর পবিত্র কোরআন থেকে তিলাওয়াত করতে আসছে আমাদের ছোট বন্ধু আনোয়ার হোসেন মোহাম্মদ আনোয়ার হোসেন পবিত্র কোরআন থেকে তিলাওয়াত করবে আমি মোহাম্মদ আনোয়ার হোসেনকে স্টেজে এসে তিলাওয়াত করার জন্য অনুরোধ করছি
السلام عليكم ورحمة الله وبركاته. أعوذ بالله من الشيطان الرجيم. بسم الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان فبأي آلاء ربكما تكذبان مرج البحرين يلتقيان بينهما برزخ لا يبغيان فبأي آلاء ربكما تكذبان صدق الله العظيم وصدق رسول النبي الكريم. السلام عليكم ورحمة الله وبركاته.
এবারে পাঠ করতে আসছে আমাদের সবার প্রিয় প্রজ্ঞা পারমিতা। কর্মমূর্তি বাসন নাম চিত্রিকিতা চর্মচিত্রে সুচিত্রে সুচিত্রা মুজুসা কাতাবা শরীবত আমকা কাতাবা শরীবত মুহূর্ত শান্তি সকল শক্তি হোক। Now, I request Dr. Oduntarani Saha to deliver her welcome speech.
Assalamualaikum. Good morning, everybody. Today we come here to inaugurate the first national conference on Down syndrome. I feel privileged to be here as a mother of Progya Paramita. My daughter Progya Paramita is a Down syndrome girl. I am inspired by my struggle when my daughter born in 1995, and by this inspiration, I decided that I try to give support and care to the parents who have Down syndrome children. And we must remember the word, today's challenge tomorrow's opportunities. And on behalf of Bangladesh Down Syndrome Association, our motto is to share that remains within the Down syndrome children. And we are doing for the opportunities to develop for the Down syndrome children since 2014, and we working for these people, and we started Bangladesh Down Syndrome Association under direct supervision of our national professor, Professor Amarkan sir, and we are working in all the levels in the world. And now we want to work with all together, physicians, therapists, and parents, social workers, all want to be in one room. And I request you all, you will come and we work together by keeping hand to hand, and ultimately we can grow a good future for the Down syndrome population. Thank you all. Assalamualaikum.
Thank you, madam. Now, I would like to request Professor Sufia Khatun, Professor of Pediatric Center for Women and Child Health, to come up on the stage and deliver her speech. Professor Sufia Khatun. Assalamu alaikum. The state chairperson, Councillor Abdul Ahmed, of the Down Syndrome Association, আমাদের সাথে আছেন চিফ গেস্ট ডক্টর মুসাল সরকারমেন্টি, ডক্টর উত্তম কুমার গৌড়া, ডাইরেক্টর অফ মেডিকেল কলেজ হসপিটাল, ডক্টর শারদা হোসেন, ভাইস প্রিন্সিপাল অফ আওয়ার ইনস্টিটিউট, ডক্টর অজয় সাহা, সেক্রেটারি জেনারেল বাংলাদেশ সোশ্যাল Down সোসাইটি, and the audience. আসসালামু আলাইকুম। আমি আপনাদের সবাই স্বাগত জানাচ্ছি। আসলে আপনারা সবাই জানছেন ডাউন সিনড্রোম একটা আইসোলেটেড ওয়ান, এবং আমরা জানি সবকিছু বেশি ভালো হয়, বেশি থাকলে ভালো হয়, বা এইখানে দেখা গেছে যে ক্রমশ একটা বেশি থাকার জন্য ভালো না হয়ে খারাপ হচ্ছে। এবং সবচেয়ে হলো যে এই যে তাদের কি থাকে তাহলে তাদের সবই টিচার এক। এবং এই ডাউন সিনড্রোম আমরা সবাই জানি ছোটকাল থেকে যে ডক্টর আমরা পড়ে আসছি যে ডাউন সিনড্রোম বাচ্চাগুলি এই তাদের যে ডেভেলপমেন্টাল ডিলে এটাই হচ্ছে প্রধান কারণ এবং বুদ্ধিমত্তা একটু কম থাকে এবং তাদেরকে অনেক যত্ন নিতে হয় এবং তাদের কি করতে হয় তাদের অনেক ধরনের কনজেনিটাল অ্যানোমালিজ এবং বিভিন্ন ডিজিজে তারা বেশি ভোগে। সুতরাং এই ডাউন সিনড্রোম বিশেষজ্ঞদের জন্য যখনই হয় কারো এজ এ ডক্টর আমাদের এক পেশেন্ট বাচ্চার জন্য হলো তো আমার খুব খারাপ লাগলো কিভাবে তাদেরকে বলবো যে তার বাচ্চা ডাউন সিনড্রোম হয়েছে। সিনড্রোমের শিশুদেরকে করতে যেটা অযোধ্যা একজন মাদার অফ ডাউন কিন্তু যে তা দাঁড়িয়ে গেল তখন আমার কিন্তু এই ডাউন সিনড্রোম সোসাইটিটা গড়ে ওঠে এবং তখন থেকে এটা মেন কাজ হচ্ছে যে এই বাবা মাকে একত্রে নিয়ে এই শিশুরা যাতে সঠিকভাবে একটা তার যে স্টেবিলিটি থাকে তার পরবর্তী জীবনে সেজন্য সঠিকভাবে জীবনযাপন করতে পারে আমাদের প্যারেন্টাল সাপোর্ট এবং এইটি হচ্ছে আসল এবং তাদের সমাধান করাও কিন্তু এই সোসাইটি একটা বিরাট কাজ। তো আমি আজকে খুবই আনন্দিত যে বাংলাদেশ ডাউন সিনড্রোম তাদের প্রথম ন্যাশনাল কনফারেন্স করছে এবং আমি খুবই আনন্দিত জানাই যে শৈশবী মেডিকেল কলেজের তারা তাদের সত্যতা সহযোগিতা এই এই অ্যাসোসিয়েশনে পালিয়েছে এবং যার কারণে আজকে সফল হয়েছে। আমি আপনাদের সবাইকে স্বাগত জানিয়ে ফেসবুক ক্লাস। Thank you, madam. Now, I would like to request our next special guest, Joel Islam Brahman, Secretary General of Sweet Bangladesh, to come up to the dais and deliver his speech. Joel Islam Brahman.
Good morning to all of you. Mr. President, Professor Dr. of Bangladesh Down Syndrome Association, and our honorable chief guest, eminent personality and the parliament member, who is also the president of Parliament Standing Committee of Ministry of Health, Mr. Shakar, the chief patron of this conference, the director of this hospital, Dr. Professor Uttam Kumar Gaura, of this the Department of Pediatric Division, Dr. Sophia Hutman, and the Secretary General, Dr. Rajan Tarani Shah. Dear friends, on behalf of Sweet Bangladesh, I congratulate the Association to hold this type of conference faster than Bangladesh. Since Down syndrome is the anomaly in the blood cell chromosome, you better know all doctors are here. They are persons with intellectual disability also. And we everybody here to come forward to help them, to cooperate with them, and to assist them, so that they can have their good child, meaningful child, and improve the main society, and enjoying their own rights as they will be. So this is for the third time in Bangladesh, observing the Children's Day on 21st March. Tomorrow will be 21st March, and as you know, the third chromosome of 21st chain of chromosome make an anomaly in the blood, and the baby or person became the problem. Sometimes neurological problem, sometimes intellectual problem. That's why the World Down Syndrome Association or Down Syndrome International has selected as the March, since it is the third month, and the 21st, and the 21st chromosome is problematic. That's why 21st March is declared as the Down Syndrome Day, World Down Syndrome Day. Outside Bangladesh, internationally observing since 10 years back. But Bangladesh Down since its foundation 2 years back, they started observing this day. With observing this day, Bangladeshi people are getting awareness, and the parents of the Down syndrome child, they are coming forward to unite it. This is for the first time Bangladesh government, Ministry of Social Welfare, under the inspiration of Down Syndrome Association, they also declared it as the government program, and tomorrow Bangladesh government will also observe and they recognize this day as the national event of the government. So we are very happy, and we thanks the government to take it into consideration and give attention. Our Honorable Prime Minister, the father of the nation, Bangabandhu Sheikh Mujib, she also very much keen and very much helpful, cooperative to the persons with intellectual disability, including the Down syndrome children. You know, our Honorable Parliament member is here. In 2013, the month of November, a special bill has passed into Parliament as Neurological Development and Disability Trust Fund Act. Through this act, including the Down syndrome children, all intellectual disabled persons will get special facility from the government. Besides this, in month of October, enacted in the Parliament in the name of the Disability Protection, Right Protection Act. Through that, the education, employment, health, cultural activities, leisure time, like other citizens, the disabled person will get it. So, we are very much grateful to our government. We hope that if the people, government, social activists, doctors, the parents will come together and work in a single line, single way, same way. So the days are coming soon when the persons with disability, including other neurological disability and Down syndrome, will get good priority, and they will also enjoy every rights, every privilege like other citizens. Thank you very much for this hearing.
valuable speech.
Assalamu alaikum. Very good morning. বিশ্ব ডাউন সিনড্রোম দিবস উপলক্ষে আয়োজিত ন্যাশনাল কনফারেন্স অন ডাউন সিনড্রোম 2016 এই ইনাগুরাল সেশনের honorable president and honorable chief guest, honorable parliament of the member and honorable member of the standing committee of health and family welfare, Dr. Kunsani Sarkar. আমি এই সভায় স্পেশাল গেস্ট হিসাবে আমাদের এই হাসপাতালের ডাইরেক্টর ডক্টর উত্তম কুমার বড়ুয়া উপস্থিত, আমাদের অধ্যাপক সুফিয়া খাতুন ম্যাডাম উপস্থিত, অন্যান্য আমাদের সিনিয়র শিক্ষকবৃন্দ এবং অন্যান্য এই ডাউন সিনড্রোম অনুষ্ঠানে যারা আগত সবাইকে স্বাগত জানাচ্ছি আমাদের ইনস্টিটিউশন শহীদ বিদ্যালয়ের পক্ষ থেকে। আমরা সকলেই জানি যে ডাউন সিনড্রোম এটা যে আমাদের যে জেনেটিক ক্রোমোজোমাল ডিসঅর্ডার যেগুলো আছে তার মধ্যে অত্যন্ত প্রিভ্যালেন্স একটা ডিজিজ, এবং এটা আমাদের দেশে যদিও সঠিক গবেষণা তথ্য নাই, তারপরেও আমরা জানি যে এটা মোটামুটি 5,000 লোক প্রতি বছর এটা জন্মগ্রহণ করতেছে ডাউন সিনড্রোমে, এবং 2 লাখ লোক এখানে আছে প্রায়, প্রতিদিন প্রায় 15টা শিশু জন্মগ্রহণ করতেছে। এবং এই ডাউন সিনড্রোমটা এটা আমাদের সমাজে বেশ ব্যাপকভাবেই আছে। সুতরাং এটা নিয়ে একটা অ্যাওয়ারনেস আমরা শুরুতেই শুনেছি, আমাদের ডক্টর অজন্তা উনি বলেছেন যে ওনার নিজের যে ডক্টর সেও এই ডাউন সিনড্রোমে আক্রান্ত। সুতরাং এই ডাউন সিনড্রোম যেটা এটা নিয়ে একটা অ্যাওয়ারনেস বিল্ড আপের জন্য এটা অনেক আগেই আমাদের যে ওয়ার্ল্ড ফুড থেকে একটা যে আমাদের 11 বছর আগে শুরু হয়েছে, সেটা বাংলাদেশেও পালন আমরা করছি। এই আমরা জানি প্রি ন্যাটাল স্টেজে যদি আমরা এটা ডায়াগনোসিস করতে পারি তাহলে সেটা আমাদের দেশে অলরেডি শুরু হয়েছে, সুতরাং সেটা একটা গুরুত্বপূর্ণ। আরেকটা গুরুত্বপূর্ণ হলো এটা যখন হয় আমরা জানি যে যাদের মায়ের বয়স যত বেশি হয় এই ডাউন সিনড্রোম হওয়ার সম্ভাবনা তত বেড়ে যায়। সুতরাং সেই ক্ষেত্রে একটা সচেতনতার বিশাল ব্যাপার আছে। এবং আরেকটা যারা ডাউন সিনড্রোম যেটা ন্যাচারালি অকার এটা সেটা ঘটবে অনেক ক্ষেত্রে যদি আমরা কিছু প্রিভেন্টিভ প্রিকশন না নিই, সেহেতু যদি ডাউন সিনড্রোম একটা একজন স্বাভাবিক মানুষ হিসাবে বেড়ে থাকবে, শুধু আমরা বলি মেডিকেল রিহ্যাবিলিটেশন, সোশ্যাল একটা রিহ্যাবিলিটেশন তাদের প্রয়োজন আছে, যারা একান্তের সাথে যেটা আজকে আমাদের যে মাই ফ্রেন্ড মাই কমিউনিটি সেটার মধ্যে যারা তারা আসতে পারে তাদের রিহ্যাবিলিটেশন, তাদের ল্যাঙ্গুয়েজ রিহ্যাবিলিটেশন, তাদের ফিজিক্যাল রিহ্যাবিলিটেশন এবং সোশ্যাল রিহ্যাবিলিটেশন টোটাল জিনিসটা আমাদের অত্যন্ত গুরুত্বপূর্ণ। এটা আমাদের ফিজিক্যাল মেডিসিন রিহ্যাবিলিটেশনের সাথে রিলেটেড। সেহেতু আমরা মনে করি আজকের এই প্রোগ্রামের মাধ্যমে আমরা এই ডাউন সিনড্রোম বাচ্চা যারা আছে তাদের জন্য সেই জিনিসগুলো আমাদের এই বাংলাদেশে আমরা নিশ্চিত করতে পারবো। এই আশাবাদ ব্যক্ত করে আজকের এই ডাউন সিনড্রোম অনুষ্ঠানে যারা আমাদের এই ইনস্টিটিউশনে কষ্ট করে আমাদের প্রধান অতিথি আমাদের যারা এসেছেন সকলকে ধন্যবাদ জানিয়ে আমার বক্তব্য শেষ করছি। থ্যাংক ইউ।
Thank you, sir. Now, I would like to request Professor Uttam Kumar Borua, Director, Shahid Sarwati Medical College Hospital, to come over the stage with his valuable speech. Dr. Uttam Kumar Borua.
আসসালামু আলাইকুম। বিশ্ব ডাউন সিনড্রোম দিবস উপলক্ষে আজকে ফার্স্ট ন্যাশনাল কনফারেন্স অন ডাউন সিনড্রোম 2016 সম্মানিত প্রেসিডেন্ট, বাংলাদেশ ডাউন সিনড্রোম অ্যাসোসিয়েশনের প্রেসিডেন্ট প্রফেসর মেজবাউদ্দিন আহমেদ, আজকের এই কনফারেন্সে প্রধান অতিথি হিসেবে উপস্থিত আছেন আমাদের চিকিৎসক সমাজের গৌরব, আমাদের অতি আপনজন, যিনি দীর্ঘদিন যাবৎ বাংলাদেশ মেডিকেল অ্যাসোসিয়েশনের নেতৃত্ব দিয়েছেন, বর্তমানে যিনি সংসদ সদস্য হিসাবে আইন প্রণেতা হিসাবে সংসদে আছেন আমাদের প্রিয় নেতা ডাক্তার ইউনূস আলী সরকার। মঞ্চে বিশেষ অতিথি হিসেবে উপস্থিত আছেন সুইড বাংলাদেশের সেক্রেটারি জেনারেল মজারুল ইসলাম মামুন ভাই এবং আমাদের এই হাসপাতালের অত্যন্ত একজন একাডেমিশিয়ান, প্রাক্তন অধ্যাপক এবং বিভাগীয় প্রধান শিশু বিভাগ অধ্যাপক সুফিয়া খাতুন এবং আমাদের মেডিকেল কলেজের উপাধ্যক্ষ ডাক্তার শাহাদাত হোসেন এবং আজকে এই অনেক আমাদের শিক্ষক মন্ডলী, চিকিৎসক মন্ডলী, ডাউন সিনড্রোমের শিশু এবং অভিভাবক মন্ডলী, আপনাদের সবাইকে হাসপাতালের পক্ষ থেকে আপনাদের জানাই সুস্বাগত। এটি বাংলাদেশ ডাউন সিনড্রোমের যিনি অত্যন্ত যার নাম আমি উল্লেখ করিনি, যিনি যার উদ্যোগে এই ডাউন সিনড্রোম অ্যাসোসিয়েশন গঠিত হয়েছে। আমাদের এই হাসপাতালের উদ্যোগী শিশু বিভাগ বিশেষজ্ঞ ডাক্তার অজন্তারানী সাহা এই সংগঠনের মহাসচিব। মূলত তার উদ্যোগেই এই অ্যাসোসিয়েশন গঠিত হয়েছে এবং তার উদ্যোগেই এই প্রথম বাংলাদেশে ডাউন সিনড্রোমের প্রথম ন্যাশনাল কনফারেন্স অনুষ্ঠিত হচ্ছে এবং ন্যাশনাল কনফারেন্সটি আজকে বিভিন্ন কর্মসূচি গ্রহণ করেছে। প্রথম সকাল 8টায় সেশন, তারপর একটা ইনঅগ্রেশন সেশন, প্লেনারি, পরবর্তীতে আমাদের সব পর্যায়ের সহ এবং উচ্চ পর্যায়ের ব্যক্তিবর্গের উপস্থিতিতে আমাদের পলিসি ডায়ালগ সেশন আছে। এর মধ্যে দিয়ে ফার্স্ট ন্যাশনাল কনফারেন্স অন ডাউন সিনড্রোম এই শহীদ সোহরাওয়ার্দী হাসপাতালে অনুষ্ঠিত হচ্ছে। তাই আমি ধন্যবাদ জানাতে চাই এবং কৃতজ্ঞতা জানাতে চাই বাংলাদেশ ডাউন সিনড্রোম অ্যাসোসিয়েশনের কর্তা ব্যক্তি, সভাপতি, মহাসচিব সবাইকে আমি ধন্যবাদ জানাতে চাই। আমাদের এই শহীদ সোহরাওয়ার্দী হাসপাতালকে বেগম হিসেবে নেওয়ার জন্য আমি তাদের কাছে কৃতজ্ঞতা প্রকাশ করতে চাই। কিছু আগে 21 তারিখ প্রতি বছর 21 মার্চ কেন এটিকে বিশ্ব ডাউন সিনড্রোম দিবস করেছেন, যেটি ট্রাইসোমি 21 যেটি অ্যাবনরমালিটির জন্য এটিকে ডাউন সিনড্রোমের দিবস হিসেবে প্রতিপাদ্য হিসেবে পালন করা হচ্ছে। এটিকে প্রথম বলা হতো 1959 সালে মেলিনগয়েড ক্রাইসিস, যেটি পরবর্তীতে আমাদের এটিকে ডাউন সিনড্রোম হিসেবে বলা হয় 65 সালে। এটি কখনোই ওয়ার্ল্ড ডাউন সিনড্রোম হিসেবে 1900 সালে এটিকে দিবস হিসেবে আমরা প্রথম পালন করি 2006 সালে এবং ইউনাইটেড নেশন এটি তাদের অ্যাসেম্বলিতে পাস করে এই কয়েকটি বছর আগে 2011 সালে মাত্র। এটির একটি কারণ আছে। আমাদের আজকে মাননীয় প্রধানমন্ত্রী জননেত্রী শেখ হাসিনা যার কথা যখন শুনেছেন আমাদের পুতুল আজকে অটিস্টিক বেবিদের জন্য শুধু বাংলাদেশে নয়, বাংলাদেশে এটা আমাদের একটা অজানা একটা বিষয় ছিল, একটা অবহেলার একটা বিষয় ছিল, একটা নেগলিজেন্সের একটা বিষয় ছিল। সেটিকে শুধু বাংলাদেশে গণসচেতনতা করেননি, বাংলাদেশের সংসদে শুধু আইন প্রণয়ন করেননি, বাংলাদেশে আজকে ঘরে ঘরে আজকে অটিস্টিক বেবিদের জন্য প্রতিটি জায়গায় তাদের মর্যাদা, তাদের অধিকার সংরক্ষণ করা হচ্ছে। আমাদের অনেক করার আছে, আমাদের দিতে হবে। নিশ্চয় আমরা শাহনওয়াজের পুতুলের নেতৃত্বে বাংলাদেশের ডাউন সিনড্রোমের রোগী, অটিস্টিক বেবিদের সঠিক জায়গায় আমরা অবস্থান করবেন। সাইমাউদ্দিন পুতুল শুধু বাংলাদেশে না, ইউনাইটেড নেশনে তিনি অ্যাডভাইজারি কমিটির মেম্বার। সেখানে আমাদের বাংলাদেশকে একটা মাথা উঁচু করে সম্মানের জায়গায় পৌঁছে দেন এই সাইমাউদ্দিন পুতুল, যার কারণে 2011 সালে আপনি এটি এখানে এটা আমাদের বক্তব্য শোনার জন্য আমরা অপেক্ষা করছি। আমি বাংলাদেশ ডাউন সিনড্রোম অ্যাসোসিয়েশনের এই প্রধান আজকে ফার্স্ট ন্যাশনাল কনফারেন্স শুভ হোক, সার্থক হোক, পলিসি ডায়ালগের মধ্য দিয়ে আমাদের সরকার একটি সিদ্ধান্তে উপনীত হোক, আমাদের ডাউন সিনড্রোমের রোগীদের জন্য প্রিনেটাল স্ক্রিনিং এর ব্যবস্থা করা হোক এবং কেরিওটাইপিং এর মধ্যে দিয়ে ভবিষ্যৎ আমাদের শিশুদের জন্য একটি আমরা ভবিষ্যতে এই এক্সিলেন্স করে ডাউন সিনড্রোমের স্ক্রিনিং এবং প্রত্যেকটি কেরিওটাইপিং করার জন্য বাংলাদেশ সরকার যাতে আমাদের সরকারি হাসপাতালকে বেছে নেন, সেজন্য আমি আজকে প্রধান অতিথি ডাক্তার ইউনুস আলী সরকারের কাছে আমাদের আবেদন থাকবে, আমাদের ডাউন সিনড্রোমের সেন্টার অফ এক্সিলেন্স হবে হাসপাতাল। আমি পরিচালক হিসেবে সকল ধরনের দেওয়ার প্রতিশ্রুতি দিয়ে আমার বক্তব্য শেষ করছি। সবাইকে ধন্যবাদ।
আমাদের সম্মানিত এমআর খান স্যার এবং প্রফেসর এম.কে তালুকদার স্যার আসার সম্পূর্ণ ইচ্ছা থাকা সত্ত্বেও পারিবারিক সমস্যার কারণে আজকে উপস্থিত থাকতে পারেননি। তবে স্যাররা উভয়ই আমাদের সবাইকে টেলিফোন যোগে শুভেচ্ছা জানিয়েছে এবং অনুষ্ঠানের সর্বাঙ্গীন সাফল্য কামনা করেছে। Now, I humbly request our chief guest, Dr. Yunus Ali Sharkar, Honorable MP and member of the Parliamentary Standing Committee on Health, to come up to the podium and deliver the valuable speech. Dr. Yunus Ali Sharkar.
Assalamualaikum. আসলে ডাউন সিনড্রোম নিয়ে যে ন্যাশনাল কনফারেন্স হচ্ছে, আমি একটু অন্য প্রসঙ্গে কথা বল। ডাউন সিনড্রোম আইতো ওটা জাতি কি আজকে ডাউন সিনড্রোম মুক্ত, অটিজমে মুক্ত, অটিস্টিক মুক্ত, মানবিক রেখা, মানবিক বাবা তার সন্তান করতে পারে, ওটা জাতি আজকে ডাউন সিনড্রোমে পড়ছে। ওটা জাতি এখান থেকে রক্ষা করতে গেলে কিন্তু আমাদের সবাইকে একটু সচেতন হবে। আজকে ডাউন সিনড্রোম সম্মেলন হচ্ছে, আমি কৃতজ্ঞ। আমি নিজকে আবেগ আপ্লুত করেছি। আমি 2জন চিকিৎসকের সঙ্গে কোয়ার্টার থাকতাম। 2জন চিকিৎসকের সন্তান কি ডাউন সিনড্রোম সন্তানের কি অবস্থা, বাবা মা এটা না হলে কিন্তু অনুভূতিতে আসে না। আজকে আমি যখন বকবিতে 17 বছর ছিলাম, আমি আমার ত্রিপুরাতির মানুষ, সেখানে ছোট্ট একটা বাচ্চা, আমার এক চিকিৎসকের বাচ্চা, বয়স 1.5 বছর 2 বছর হবে, একটা প্লেটে রিপেয়ার করতে গিয়ে আমি অ্যানাস্থেসিয়া দেওয়ার সময় ইন্ডোট্রাকে টিউবটা দিতে পারছিলাম না। অনেক কষ্ট দেওয়ার পরে এটা পেটের আলটিমেট সেভ হলো, প্লেট করা হলো, লিক করা হলো। তার পরবর্তী পর্যায়ে আস্তে আস্তে আমার সামনে বাচ্চারা বেড়ে উঠলো। কি অমানবিক এই কষ্ট বাবা বেড়ে গিয়ে অন্য বাসার ঢুকে ফ্রিজ করে বৃষ্টি টিকাতো, যে বুঝতো সে কিছু বলতো না, যে বুঝতো না তার যে আচরণ ছিল, যারা না বোঝা মানুষ এবং চিকিৎসক যে আচরণ ছিল, ডাউন সিনড্রোমের 50% চ্যালেঞ্জ এই যে অটিজম, ডাউন সিনড্রোম, অটিস্টিক কেন হচ্ছে জানেন? আমার ছোটটা মানুষকে অনেকে বলে যেহেতু ছায়ামাওয়াদের পুতুল এইটাতে জড়িত, আসেন সবাই মিলে করি কিন্তু করি খাই। ডাউন সিনড্রোম, অটিস্টিক অটিজম সব দুই একসাথে সবাই মিলে। প্রত্যেকটা ইউনিয়নে সুই ফাউন্ডেশনে স্কুল হচ্ছে, স্কুলে প্রাপ্ত নিয়োগ করা যাচ্ছে, নিয়োগ মানে কারিগর। এই সব নিয়োগ কাগজে আছে আপনার আমার মনে হয় এটা বাস্তবতা। আসলে আমরা সবাই মিলে ভয়েস রেজ করি, কাউন্সিলের পক্ষে কথা বলি, অফিসি বিষয়ে কথা বলি, তার সাথে সাথে আসলে আমরা সবাই মিলে আওয়াজ করি। আসলে মাদকমুক্ত সমাজ না হলে এই অসম্ভব ব্যাপার, অসম্ভব, খুব করুণ অবস্থা। পার্লামেন্টে দাঁড়িয়ে সত্য কথা সাহস করে বলার জন্য নাই, কারণ আমরা গোলাম বলা চলে, গোলাম সব সত্য কথা শাসনের মধ্যে কিন্তু অনেক আত্মাহতি হয়েছে, অনেক দেশাত্মীয়তা হয়েছে। যাই হোক, আমার অনুরোধ আপনারা বলেন 29টা সম্ভব আমার ব্যক্তিগত আসুন না সুবিধা বঞ্চিত বাচ্চাদের জন্য আমরা আলাদা একটা মন্ত্রণালয় করি, যেটা থাকবে প্রধানমন্ত্রীর মন্ত্রণালয়ের অধীনে। তাহলে এই মন্ত্রীটা আপনার ভয়েস রেজ করবেন, আমি আমার ভয়েস রেজ করবো, কথা বলতে একসাথে ভালো লাগে না। যেটা বলি এটা পড়ছি কোনো কথা বলি। আজকে বাংলাদেশে হেলথ সার্ভিসে কি হয়েছে, হেলথ সার্ভিসে 4.2 হলো জাতীয় আপনার বাজেটে আমাদের অ্যালোকেশন, মাত্র 4.2, এটা 100 বছরের 7.5 নামতে নামতে 0 করতে আমরা বড় বড় নেতা করি, কেউ বিয়ে করি, এই চিকিৎসা পেশার যে অবস্থা হবে, ডাউন সিনড্রোম মেডিকেল কলেজ 102টা, অ্যানাটমি টিচার হলো 3 জন, ফিজিওলজি হলো 18 জন, পড়ে যায় 102টা মেডিকেল কলেজে কোথা থেকে লেখাপড়া। শুধু এমন এক সময় আসবে মেয়ের আর ফিমেল কি করে ডাক্তার সাহেবরা, এর বাইরে সম্ভব নয়। তাহলে আসুন সবাই মিলে আপনি বিশেষ কর্তৃত্ব করুন, বিশেষ ডাউন সিনড্রোমের যে অ্যাসোসিয়েশনের অত্যন্ত উদ্যোগী, আপনারা একটা প্রোটেক্ট প্রোভাইড দান করেন, প্রোটেক্ট প্রোভাইড আমরা শোনেন মনে কিছু নিয়েন না, নিজের দোষ আমার নিজে পিটাইতে হবে, অন্যকে পিটাইতে দিলে ভাগে লাগবে। তাহলে কতটুকু পার্টি পাচ্ছে আমি বিশেষভাবে অনুরোধ করবো মামুন ভাই, সুই বাংলাদেশের সেক্রেটারি জেনারেল অগ্রতা আছে, ভাইরা আছে, সবাই মিলে একটা প্রজেক্ট প্রোভাইড আপনারা দান করেন। যে প্রজেক্টে আমি ঝগড়া একটু ভালোবাসি, ঝগড়া করতে পারবেন, তার কারণে এই প্রজেক্ট একটা বুদ্ধি মরণ, বোমামা মরণ। এই মরণদের মরণ হচ্ছে আমার নেত্রী বিশ্বনেত্রী জননেত্রী শেখ হাসিনা, বিশ্বরত্ন। আমি শেখ হাসিনার মায়া আছে, অনুভূতি আছে, আবেগ আছে, কর্মকর্ম করার ইচ্ছা আছে। আপনার একটা প্রতি দরকার, আমি ওয়াদা করছি যে আমার এই চাপা ভাই সপ্তাহে আসছে, চাপা সপ্তাহে দেওয়া হয় না। এই চাপাতে মাছের বেচেটার মাছের সাপটাকে ছোট ছোট পাইছেন না, এই নামতে হবে না, এই নামের তবে 60টি নাম এখানে লাগাইতে হবে, এছাড়া সম্ভব না। আমার জীবনে খুব শখ ছিল যে একটা পার্লামেন্টের মেম্বার হবে, সব মিটিং এ চলে একদম মিটিং এ সব। যাই আমি বিনয়ের সাথে বলছি, আপনারা ভয়েস রেজ করেন, যেটুকু সাহায্য আমি করতে পারবো এটা অবশ্যই করবো। সবাইকে ধন্যবাদ এবং সবার কাছে কৃতজ্ঞতা জানিয়ে আমি আমার বক্তব্য শেষ করছি। জয় বাংলা, জয় বঙ্গবন্ধু, জয় বঙ্গবন্ধু।
ধন্যবাদ স্যার, অত্যন্ত সুন্দর প্রাণোজ্জ্বল বক্তব্যের জন্য। আমরাও এখন অপেক্ষায় থাকবো স্যারটির নামে চাপা দিয়ে যেন পরবর্তীভাবে ডাউন সিনড্রোম অ্যাসোসিয়েশন সহ সকল প্রতিষ্ঠান এগিয়ে দিতে পারে। Now I request Professor Mr. Down Syndrome Association to come to the dais and deliver his speech.
Assalamu alaikum and good morning. This is a very for us, and because for the first time in Bangladesh, investigation, and of this honorable gathering, our respected member of the parliament, Dr. Shafar, and he is not only the member of the parliament, he is a member of the parliamentary session on health. And Professor Uttam from Bolua, I know him long before. He is a very dynamic person and he has committed a lot of things. I think we can do something. Sophia Khatun, the partner of this medical college, and on the dais, vice principal of the college, Professor Dr. Shahar Hussain, my friends, the secretary of state, and all the name, without whom I cannot run this Ajanta Shah. My dear colleague, I want to introduce one lady who came all the way from Brazil to Dhaka to attend this conference. She is Dr. Berry. Please, Dr. Berry, please stand up. She is Dr. Berry from Brazil. She came all the way from Brazil to attend the conference. On behalf of our Bangladesh Council Association, I comment. উপস্থিত ছিল বর্তমানে আজকে দিনটি আসলে কিছুটা আবেগে অযোধ্যা যে আবেগের কথা বল আমার কিছু আবেগ আছে একটি সরকার হয়েছিল 2000 সালে সেটা ধর্ম ছিল ছিল ওয়াজ ছিল কাছাকাছি এই পরিষ্কার রাখলো আমি আমার শিশুকে 22 দিনের বেশি বাঁচিয়ে রাখতে পারিনি অনেক চেষ্টা করতে করে তাকে ধরে রাখতে পারি পৃথিবীতে বিস্তার ক্লাস 14 বছর বয়সে একটি মেয়ে থাকা যাই হোক সেই অনুপ্রেরণা থেকে আমি আমার এই প্রেসিডেন্টের দায়িত্বটা আমি দিয়েছি কোর্টের তা দেখো তুমি কি ফ্যামিলি সারাতে বলে আমি দিতে পারছি আমার একটা পিছনে একটা কথা আছে আমি 2011 সালে আমি গোয়া থেকে যে এই দশক খরচ আছে কমে সেখানে দেখি অযোধ্যাকে প্রজ্ঞা পালনটা এমন সুন্দর একটা রাজ করলো সেই where she came from. আমরা বললাম she is from Bangladesh. এবং অযোধ্যা ঢাকা এসে বললো মেজর ভাই আমি তখন বাংলাদেশ পিটার ক্যান্সারের সেক্রেটারি জেনারেল তখন দায়িত্ব প্রাপ্ত মেজর ভাই কিছু করতে হয় তখন আমরা এই প্রতিষ্ঠানকে রূপ দিতে আমরা চেষ্টা করলাম আলটিমেটলি আমি আজকে বলতে চাই আলহামদুলিল্লাহ সাকসেসফুল হয়েছি আমরা ন্যাশনাল কনফারেন্স করছি আর welcoming them. We have been able to convince our government to work in cooperation with all the faculties who are working for the benefit of cancer in this country. And they will be that day, will be cooperative. And I'm very happy to say, with the government executive committee, our Vice Secretary General Odota is the member secretary of the government affairs regarding this celebration day. এখানে কয়েকটি গাউসের বাচ্চা আমার কাছে আছে আমি একটা ছেলেকে দাঁড় করতে চাই এই ছেলেটি দেখুন সামনে বেঞ্চে দাঁড়িয়ে আছে হি ইজ দ্য ফাদার অফ স্পেশাল ভেরি বিউটিফুল চাইল্ড আই স্ট্যান্ড আপ হি ইজ দ্য ফাদার অফ টু বিউটিফুল চাইল্ড হি ইজ স্টেইং উইথ আস ইন ওয়ান কমিউনিটি দেখেন এই শিশুগুলিকে কিন্তু আমরা অবজ্ঞা করতে পারি না এই শিশুগুলিকে কিন্তু আমরা নিয়মিত শিক্ষা নিয়মিত ট্রেনিং দিতে পারি নিয়মিত কাজ দিতে পারি তারা একটা ফাদার হতে পারে শিক্ষা পালনটা মা হতে পারে আমাদের দায়িত্ব ওদেরকে হাউ টু টিচ দেম হাউ টু লার্ন দেম এবং তাদের যে পটেনশিয়ালগুলো আছে সেই পটেনশিয়ালগুলোকে আমাদের আনলক করে বের করতে হবে আমি অত্যন্ত কৃতজ্ঞ আমাদের মাননীয় এমপি সাহেব উনি কথা দিয়েছে উনি পার্লামেন্টে বলে আমাদের প্রতিষ্ঠা ছেড়েছেন আমরা অবশ্যই করবো এবং প্রত্যেক সবসময় যদি সাহায্য পাইয়ে দেন আমরা তাদের কাছে কৃতজ্ঞ আমি মনে করি আমাদের আজকে সেকেন্ড যে সেশন হবে পলিসি ডায়ালগ সেখানে আমাদের অত্যন্ত গুরুত্বপূর্ণ ব্যক্তিবর্গ বাংলাদেশ সরকারের পক্ষ থেকে থাকবেন সেক্রেটারি থাকবেন সমাজসেবা সেক্রেটারি থাকবেন এশিয়া সেক্রেটারি থাকবেন বিএনএ মহাসচিব থাকবেন
হলচলচাল দেশীয় থাকবেন, আমাদের অত্যন্ত অবদান হবে, আমরা সর্বভাবে থাকবে। সুতরাং আমি বক্তব্য বেশি করতে চাই না, আমাদের সাংস্কৃতিক শেষ আছে, আমি মনে করি আমরা এগিয়ে যাবো একসাথে সবাইকে নিয়ে। এখানে আমাদের আজকের স্লোগান মাই ফ্রেন্ডস মাই কমিউনিটি, the benefit of inclusive environment for children and tomorrow's adults. সবাইকে অত্যন্ত ধন্যবাদ এবং আল্লাহ হাফিজ। আসসালামু আলাইকুম।
Thank you, sir, for your directive speech. Now, I'd like to request Barrister Taposh Shanti Ball to give vote of thanks, Treasurer of Bangladesh Down Syndrome Association, Barrister Taposh Shanti Ball.
Good morning, everyone. I feel privileged to be on this dais in spite of being a lawyer, because this is the dais for all the doctors and the parents. So first of all, I would like to give thanks to all our honorable guests, especially the chief guest, for giving us the time on such a busy day. And also I'd like to thank every doctor to have their time, for having the time to attend this conference. We hope, as our president wished, that we will go all together. And finally, I would like to thank all the volunteers who have made this and gave their valuable time and making this program a great success. Thanks to everyone. Thank you.
Thank you. Now, we are going to start our scientific sessions. I would like to request our chief guest, special guests, to please come over and have their seats. Audience, we are going to start our plenary session 1, MS Arbor session. The session will be chaired by Professor Farhana Dewan, Professor and Head of the Department of Obstetrics and Gynecology, Shohid Sohrawardy Medical College Hospital, and Professor Mohindra Nath Rai, and Head of the Department, Biochemistry, Sir Solihulla Medical College Hospital. For this session, we have 4 speakers. First of all, we have Professor Firooza Begum, the legendary professor and pioneer in antenatal screening in Bangladesh and key person of fetal-maternal unit of then Mr. Sharif Akhtar-Jaman, PhD, Professor and Chairman, Department of Genetic Engineering and Biotechnology. Professor Nazmin Kobi, Professor of Obs and Gynae and Executive Director of ICMH. Dr. Ridwan Karim Kajal, Associate Professor of Ops and Gynae, DSMNU. I would like to request our chairperson, Professor Farhana Dawanwala and Professor Yunjo Nazwai, to please start the plenary session. Dear audience, I would like to draw your attention. National Conference on Down Syndrome 2016. Our today's conference and the board is online now at the website of Bangladesh Down Syndrome Association. Is www.bds.bd.org. www.bdsa.bd.org. I would like to request the speaker of this session to please come over to the dais.
Learned audience, I, on behalf of the first session, in the name of our decorated pediatrician and former member of parliament, Professor M.S. Akbar, plenary session, we are going to start this plenary session, chaired by Professor Anton on my right side. I am Professor Anton on the right. We are sharing this session. We are in this session, 4 papers will be presented. First, one by Professor Firoza Begum, Professor of Internal Medicine, DSMNU. Second paper will be presented by Professor Sharif Akhtaruজ্জামান, Professor and Chairman, Department of Genetic Engineering, Biotechnology, University of Dhaka. Third paper will be presented by Professor Nazmin Tobi, Professor of Obstetrics and Gynae. And now, Executive Director of ICMH, Mathura. Fourth paper will be presented by Dr. Rizal Karim Kajal, Associate Professor, Department of Ops and Gynae, DSMN. Now I am requesting our Honorable Chairperson, Professor Farhana Dawan, Professor of Ops and Gynae, Sheikh Chowdhury Medical College and Hospital.
Thank you. Respected audience and friends, welcome and good morning. I'm really privileged to have the honor of chairing this very important session. From morning in the inaugural session, we have been hearing about Down syndrome, and we know the importance of Down syndrome. So, is Professor Firoza Begum. I think many of you know her, and she is an eminent personality, and she has a special place in obstetrics and gynecology because of her past experience and her knowledge about it. So, Professor Firoza Begum passed her MBBS in 1979 from Sir Solimullah Medical College, and she got her fellowship in obstetrics and gynecology from BCPS in 1987. She has more than 100 publications in reputed national and international journals,
and she is now the fetal maternal. She's also the pioneer of fetal maternal medicine, and she's in management of high-risk pregnancy in this country, and she's working as the head of the fetal maternal medicine in BSMNU since establishment in 2006. She has a number of international trainings on prenatal screening, on fetal handicap, Bangkok, and also from Switzerland. So, dear audience, I would like to invite Professor Firoza Begum to make her presentation. Respected Chairperson and Co-Chairperson of today's first National Conference of Down Syndrome, I am very much happy by hearing the nice words from our today's Chairperson, Professor Farhan. And you all know Down syndrome is the most common chromosomal abnormality, but the key is that the baby has got a Down syndrome can be diagnosed before the baby is born. Respected Chairperson, I have been invited by the Bangladesh Down Syndrome Association to talk on the prenatal screening of Down syndrome. And before I start my presentation, I would like to thank the organizers, particularly Dr. Ajanta, for inviting me. Now, what is Down syndrome? Condition has been described 150 years back by an English scientist, John Langdon Down, and by looking at the typical phenotypic features of the baby. In addition to typical phenotypic features, individuals with Down syndrome has moderate to severe mental retardation. They have learning disability, developmental delay, and some health problems like cardiac defect, vision, and hearing problems. And all this causes high financial and psychological burden to the affected family. Ladies and gentlemen, we exactly do not know the prevalence of Down syndrome in our country, but the estimated prevalence in the USA is 9.2 per 1,000 live births. The number is quite high. Now the question is, how Down syndrome occurs? We know all cells of our body has 23 pair of chromosomes. In individuals with Down syndrome, there are 46, that we have every cell of our body has got 46 chromosomes. But in individuals with Down syndrome, they have 47 chromosomes. There is one extra chromosome in chromosome number 21. And this happens by non-resorption during basis. A small percentage of Down syndrome baby actually is a mosaic. That is, they have in their cell they have normal chromosome complement, as well as some cells have trisomy 21. Down syndrome can also occur by translocation. Here, some part, not a full chromosome is attached, but a part of the chromosome is attached to other chromosome. Part of chromosome 21 being attached to other chromosome. Most likely, the chromosome involved is chromosome 14, but it may be attached to chromosome 13 and 15 as well. Here we see the picture of the Down syndrome trisomy and this Robertsonian translocation. The Robertsonian translocation can be transmitted from the father or the mother to the baby. Now, what is prenatal screening? Prenatal screening identifies the likelihood of having a disease or a condition in a fetus before the baby is born. And prenatal diagnosis either confirms or refutes the actual presence of this condition. So, what is the aim of this prenatal screening? Prenatal screening aims to identify the woman who is at sufficiently high risk to having an affected child so that we can offer them invasive procedures. Now, a little bit about the prenatal history of prenatal screening. That Down syndrome has got an association with the maternal age was recognized in 1930. And in 1956, a French scientist, has discovered that it is caused by chromosome. And since 1980, several prenatal screening tests are being used. These include the double test, triple test, or quad test. In 1990, the integrated test, that is the nuchal translucency measurement, along with the double test or the triple test. And very recently, in 2011, some Chinese scientists discovered that fetal DNA is available in the maternal blood, and since then, non-invasive prenatal testing are used. Ladies and gentlemen, I have already mentioned that Down syndrome has got some association with the maternal age. This slide shows that the Down syndrome risk is almost constant between the age of 20 to 25 years, and thereafter it rises. At the age of 20 years, woman has got a risk of 1 in 1650 of having a Down syndrome baby, and it becomes 1 in 350 at the age of 30, becomes 1 in 100 at the age of 40, and becomes 1 in 30 at the age of 45. So our next question is, should we screen the women above the age of 35? We know most of our babies are born to women below the age of 35. So if we screen the women above the age of 35, we will miss 70 to 80% of the Down syndrome baby. In 2007, the American College of Obstetricians issued a circular where the pregnant of their age to have the option of diagnosis. Maternal age of 35 no longer should be used by itself. Now, what are the techniques that can be used for prenatal diagnosis of Down syndrome? Various techniques are used, some are non-invasive and some are invasive. Among the non-invasive methods, there is maternal serum screening, which can be started as early as in the first trimester, between 19 to 40 weeks. And in the second trimester, serum screening includes triple test or the quad test. And there are many ultrasound markers. These are all non-invasive. And in the first trimester, we can look for the buccal translucency, where it is nasal bone, vacus venosus doppler, and tricuspid regurgitation. By this, we can detect, we can suspect that the baby has got a Down. And in the second trimester, if the woman comes late, what we can do? We can still do help some. We can do some help to them. There are many sorts of syndrome. That is, there are many ultrasound markers. By looking at this ultrasound marker, we can suspect that whether the baby has got Down syndrome. And for confirmation, we will do some invasive testing. If the woman comes early, we can do podial reverse biopsy between 11 to 14 weeks, 10 to 14 weeks, and we can offer amniocentesis if you come late, 15 to 18 weeks. Now, what is the value of this serum screening? If we do the serum screening, that is pregnancy associated with plasma protein and 3 beta hCG, along with if we do the nuchal translucency, 85% of the cases of Down syndrome can be detected. But the false positive is high, 5%. And if we combine this first trimester screening and the second trimester serum screening, along with nuchal thickness, almost 95% cases of Down syndrome can be detected. Again, the false positive rate is 5%. So there is some problem with this serum marker. Because the serum marker varies from lab to lab, depending on the assay method, it depends on the woman's age, it depends on the woman's body weight, ethnicity, and number of pregnancy, and some medical disorders like diabetes. Therefore, these serum markers are usually expressed as multiples of median weight, considering one as the population median. So to become significant, for example, beta hCG must be more than double of the multiples of median value for that population. And PAPA must be half of the multiples of median value for that population. Alpha-fetoprotein and alpha-fetoprotein should be 25% less for the multiples of median value for that population. And this is the first trimester combined test. We call it combined test because it combines the ultrasound marker as well as the serum marker. And here we see that the nuchal translucency is almost double to become significant, beta hCG double and PAPA half. The second trimester serum marker, alpha-fetoprotein and HDL is low, beta hCG and immunity is high with Down syndrome. Now, regarding the first trimester ultrasound markers. First trimester ultrasound, among the ultrasound markers, first was used the nuchal translucency. Now, what is nuchal translucency? Nuchal translucency is nothing but a soft tissue thickness behind the nape of the fetus, behind the cervical spine. And normal range is 2.5 to 3 millimeters. And it is present. So, if it goes above 3 millimeters, will we call the baby a Down syndrome? No. Because this nuclear translucence is found in 75% of the babies of the Down syndrome, it is thick, but it can be found thick also in other chromosomal abnormality and also baby with the cardiac abnormality. And in 2% cases of normal nucleoid fetuses, the nuclear translucence is thick. In 2002, Nicolaides and her colleagues identified that the babies with Down syndrome has hypoplasia of the nasal ring. And again, this is found in 70% of the cases of the Down syndrome baby and 1% cases of normal babies. That is, the nasal bone is either absent or small. Ductus venosus Doppler, we know ductus venosus has got always a forward flow, but in case of Down syndrome, 64% cases the ductus venosus Doppler is either ductus venosus flow is absent or reversed, and this is present in 4% of the normal baby. Tricuspid regurgitation, again, it is regurgitation is present in 60% cases of Down syndrome baby and 2% cases of normal nucleoid fetuses. So none of these screening tests can confirm whether the baby is a Down or not. So what are the next options? We can do, if there is a suspicion, we can do some invasive testing like Korean villus biopsy and amniocentesis. The benefit of Korean villus biopsy is that here a small portion of the villi is taken out through the abdominal route, and as the villi is a highly divided cells, the chromosomes, many cells are in the mitotic state and the chromosomes can be started directly. So we can get the result within 24 hours. But the problem is, it is a procedure related risk is high, 1%. Now regarding amniocentesis, here 10 to 20 ml of fluid is taken out from the amniotic cavity. The fluid is then spun and a fillet of amniotic cells are. These cells are, and on this cultured cell, the cells are chromosome analysis is done. So it takes 10 to 14 days to get the result, but it is safe than that of the Korean villus biopsy as regarding abortion. Now I have already mentioned that there are many ultrasound shock markers. So, for example, brachycephaly or elongated fetal head, pterodactyly, echogenic bowel, echogenic intracardiac focus, nasal bone, hypoplasia, nuchal pore thickness, and so on. There are so many ultrasound markers of Down syndrome. Here you see, this is the nuchal pore thickness, this is the soft skin thickness behind the occipital bone of the fetus, and normally it should not be more than 5 mm. But in Down syndrome baby, it goes above 6 mm. This is an intracardiac focus, and this is a double bubble appearance because of the duodenal atresia. This is echogenic bowel, and this is the absence of the middle phalanx of the digit, and this is the central gap of the foot. So, these sonographic markers, can these sonographic markers again diagnose Down syndrome? The risk ratio rises with the number of markers. That is, if we get 3 markers positive, the likelihood ratio of Down syndrome is 80 to 150. So, it depends on the number of sonographic markers we get, that the baby has got a Down syndrome or not. Ladies and gentlemen, the current screening as well as invasive testing have got some limitations because there is high false positive rate in the screening test, serum screening, and the information of serum screening does not come till late second trimester. So the woman has to go to the lab several times to get the result, and many women are concerned regarding the procedure related to loss of the fetus in invasive procedure. So non-invasive prenatal testing has come into use. NICT removes the risk of procedure related risk, and women may be less likely to decline the test. We all know cell trafficking is a normal phenomenon. Fetal cells as well as fetal DNA is available in the maternal blood from very early pregnancy, since 7 weeks onwards. But fetal cell is very scarce, 1 in a billion of total cells. And fetal DNA is abundant, from 2 to 30% of the total DNA in the maternal blood is cell-free DNA. So we can test this cell-free DNA in the maternal peripheral blood and detect whether the baby has got Down syndrome or not. But the next question is, can it replace the current method of invasive testing? Probably the answer is no. The American College of Obstetricians and Gynecology and the Society of Maternal Fetal Medicine Foundation, they made a joint opinion that cell-free DNA testing should not be part of routine prenatal lab assessment. It should not be offered to women with low-risk women. And patients with positive test should be referred for genetic counseling and offer invasive prenatal diagnosis for confirmation of the report. So, at present, cell-free DNA does not replace the accuracy and diagnostic precision of prenatal diagnosis using amniocentesis and follicular births. Ladies and gentlemen, now regarding the prenatal screening history in Bangladesh, as a fetal-maternal medicine specialist, I have started prenatal screening since 2004. At that time, we screened only the high-risk women by doing a fecal translucency test, serum screening test, and in case of suspicion, we offer amniocentesis. Since 2014, we have changed our strategy. Now we are doing fecal translucency measurements, nasal bone, fetal heart rate, Dr. Doppler, and tricuspid regurgitation for all women between 10 to 40 minutes. And if this result gives some suspicion, we will offer them fecal test. And if this both give suspicion, we will offer them invasive procedure, that is amniocentesis. Ladies and gentlemen, in conclusion, I will just summarize the recommendation from the ACOG and ACOG recommendation is that all women should be offered aneuploidy screening before 20 weeks of gestation. Patients in early pregnancy should be offered both first and second trimester screening. And the screening strategy will depend on the availability of the CBS and the person trained in fecal translucency measurement. Here I would like to mention that fecal translucency measurement needs certification from Fetal-Maternal Medicine Foundation. If CBS is not available in any part, then we can offer integrated testing. Integrated testing means first trimester serum testing along with fecal translucency. If fecal translucency measurement is again not available or cannot be obtained, we can offer serum integrated testing, that is include the first trimester serum testing and the second trimester serum testing. Now, what is FIGO recommendation? FIGO recommends that the first line screening of trisomy should be achieved by combined test, which includes maternal age, fecal translucency measurement, fetal heart rate, a double test. And this together has got a 90% detection rate of Down syndrome with a false positive rate of 25%. And this detection rate can improve to 95% with a false positive rate less than 3% if we combine nasal bone, Dr. Doppler, and tricuspid regurgitation along with this. Ladies and gentlemen, prenatal screening of Down syndrome has become an integral part of antenatal care in many countries of the world. As the number of congenital abnormalities in our country has increased, I would request all my colleagues to do prenatal screening by ultrasound of their patient between 10 to 40 minutes. Thank you all.
I would like to thank Professor Firoza Begum for a very illuminative and extensive presentation. I think all of us have been immensely benefited. I'm not sure about the time, but I would request you to have limit your questions to the end of the session. If we get time, we may give you the chance to ask at least one or two questions to each of the presenters.
Thank you all. Now we are going to represent the second paper of this session. The topic of the paper is quantitative fluorescence PCR, polymerase chain reaction, a suitable alternative of karyotyping in prenatal aneuploidy detection. This paper will be represented by Dr. Jaman, PhD, Professor and Chairman, Department of Genetic Engineering and Biotechnology, University of Dhaka. I want to take the privilege to introduce him. He is an academician as well as scientist involved in genetic engineering and biotechnology. Some of us are oriented that is involved in the DNA laboratory attached to Dhaka Medical College, that is forensic department of Dhaka Medical College, which plays an important role in crime detection. We are also familiar that that laboratory plays a very crucial role during the period of criminality or VDR carnage for detection of nearest and dearest ones. That laboratory played a vital role. Professor Sharif Akhtar is a key person involved with that laboratory. Is involved in various research and scientific activities. Now I am inviting Professor Sharif Akhtar to present his valuable paper.
আমি একটু অডিয়েন্সকে রিকোয়েস্ট করব, আপনারা প্লিজ একটু মনোযোগ দিয়ে শুনবেন। আপনারা কথা বললে যারা শুনতে চান তারাও শুনতে পারেন না, যারা প্রেজেন্ট করেন ওনাদেরও অসুবিধা হবে। অনেক কষ্ট করে কিন্তু প্রেজেন্টার পেপার রেডি করে আসেন। প্লিজ একটু কষ্ট করে শুনবেন, এখানে অমনোযোগী হবে না, কথা বলে অন্যদের ডিস্টার্ব হবে। থ্যাংক ইউ ভেরি মাচ।
Thank you very much for introducing me. Respected audience, ladies and gentlemen, very good morning to all of you. First of all, I would like to express my sincere thanks and gratitude to the organizers for having been invited as a speaker in this novel academic pursuit. Today I will talk about the quantitative fluorescence PCR or qPCR as a suitable alternative for karyotyping in prenatal molecular detections. This is just a picture taken from the last year where I had the opportunity to interact with these down babies where they came with their parents to share their experiences with us and also some of our friends. Actually, I don't have any precise statistics about the incidence of Down syndrome in our country, but according to an unofficial report, there are approximately 15 live births per day, and which accounts for approximately 3,000 to 5,000 births per year. And that means altogether we may have about 200,000 families who are already actually Down syndrome or any kind of chromosome aneuploidy is the result of a failure of homologous chromosomes or sister chromatids to separate properly during paternal either paternal or maternal levels. So the result is the formation of two types of gametes, both of them are abnormal, and either of these abnormal gametes, if the normal gamete can result in also. This you can see, this is a kind of meiosis, and in second meiosis, both the chromosome has gone to one gamete, and this gamete is got the chromosome. And again, the same thing in the first meiotic division, this cells, this gamete did not receive any chromosome, and this cell, this gamete, and this is both the chromosomes. So as a result, you can see this is a trisomy, this is a monosomy. There are two trisomies and the monosomy. So these are the in general consequences of non-cis junction that happens. So Down syndrome, as you have already learned, that Down syndrome means there is a trisomy of chromosome 21, and you already have learned about the consequences of this chromosomal abnormality. In addition to Down syndrome, there are other chromosomal abnormalities like Edwards syndrome, which is a trisomy of 18, and the Farrow syndrome, which is a trisomy of 13, and they all have this kind of clinical presentation. And particularly Edward syndrome, you see there is a kind of facial deformation like this. Apart from these abnormalities are associated with autosome, not the sex chromosome. But there are also chromosomal abnormalities that is related to sex chromosomes, and we call it sex chromosome aneuploidies. These include Turner syndrome, 45X, that means you don't have the Y chromosome. Klinefelter syndrome, you have one extra X chromosome. Triple X syndrome, you have 3X. The Jacob syndrome, you have one extra Y chromosome, and they also have this kind of clinical presentation. So, non-disjunction may cause both autosomal aneuploidy and as well as sex chromosome aneuploidies. And these aneuploidies are straightforward aneuploidies, that means there is either addition or deletion of a complete chromosome. But sometimes we do not pay much attention about translocation, what already has pointed out by our previous speaker. That is the chromosomal translocation. Translocation are two types. One is the reciprocal translocation, and in reciprocal translocation, it involves breakage and reunion of two and any pair of the chromosome can be involved. But now, if you do a karyotype, you will find there are 46 chromosomes, but there is a translocation. Again, it is something like this. If you do a karyotype, you will find that you have 46 chromosomes. There are other kinds of translocation which is known as Robertsonian translocation. Robertsonian translocation actually involves only acrocentric chromosomes, particularly chromosome 13, 14, 15, 21, and 22. So it results in the formation of new chromosome consisting the whole long arm of the two acrocentrics involved. Like this. This chromosome has another chromosome. 21 should have been 221 chromosome. One chromosome has been fused with this chromosome 14 and has the Robertsonian translocation. So let us see what are the consequences of these two kinds of translocation. The outcome of balanced translocation is that you have these three consequences. You have normal zygote, you may have balanced carrier. They are really dangerous. And they are carriers, but you cannot understand by conventional karyotyping unless and until you do a precise molecular test. Otherwise, you will apparently see them as normal. And then again, the other possibilities are there might be a partial trisomy, or partial monosomy, or partial monosomy plus partial trisomy. These are the consequences of the balanced translocation, and they are apparently normal. But these people, they are balanced carrier, they are normal, but risk to the children having unbalanced translocation. And these two type of people, they are actually abnormal. Then, what is the outcome of the Robertsonian translocation? The two normal chromosomes and the Robertsonian translocation chromosome in a carrier can segregate in three ways. Like this, normal, balanced carrier, and also you can have translocation trisomy or monosomy 14, and also you can have monosomy 21 or translocation Down syndrome. This is also a Down syndrome, please remember, but they are translocation Down syndrome. So they are not normal like the normal Down syndrome, they are called translocation Down syndrome. And the incidence already discussed, advanced maternal age is one of the main issue. And you can see that with the age, the incidence of trisomy increases. Also, geographical variation is one of the important factors, and some environmental factors are also there. As for the current state of diagnosis, there are three different kinds of diagnosis. Of course, I did not include non-invasive diagnosis already discussed by our previous speaker, like immunological tests and biochemical tests. So there are conventional karyotyping, which is done by either G binding, R binding, or Q binding. They are basically the same, but they use different kinds of dye, and the dye binds in different regions of the DNA. That say for example, the ginseng dye binds to the acute region, or the acrylic dye binds to this region, and so on. Then the next option is the fluorescent in situ hybridization, or which is most popularly known as fish. And the third only bias on fluorescence here. But I just skip this slide because you already know this. And you are urban, this is a normal karyotype. You see a normal karyotype like this, but when you have a trisomy, you will have three bands like this. But in practice, you will never see a karyotype like this after karyotyping the chromosomes and haphazard. So you have to be very expert in sorting this chromosome based on their numbers. Then fluorescent in situ hybridization is based on painting of the chromosomes, a portion of the chromosome with fluorescent level probes. These probes, actually, there are four kinds of probes. It might be gene specific, it might be centromeric probe, it might be telomeric probe, or you may paint the whole chromosome. So, depending on the type of painting or probe you use, your result will be visualized under the microscope like this. If you use a centromeric probe, you will see dots like this. If you target a particular chromosome, if you use a locus-specific probe, you see also dots. If you use the whole chromosome painting, only then you can visualize the whole chromosome. And also, if you can paint every chromosome with different colors, then you will be able to identify the fluorescence PCR, this is another PCR-based technique. This is a variant of PCR. You know, PCR is a molecular biological technique that can amplify a target DNA into millions of copies. So I am now not going into the details of this method, but this qPCR, this method relies on the amplification of polymorphic STR sequences, which is specific to chromosome 13, 18, and 21, as well as the sex chromosomes. So STRs are basically short sequences which is repeated many times. Say for example, this is the 2 chromosome, and you have this sequence on both the chromosomes, and this sequence has been repeated 7 times in both the chromosomes. So you get a peak like this. And here again, this chromosome has 8 repeats and the other chromosome has 30 repeats. So you get a 2 peaks like this. So for a normal diploid component, you get either 1 peak or 2 peaks. But if you have a 3 chromosomes, you either get 3 peaks or 2 peaks with a different ratio. I show you just now. So this is a normal diploid component. So you get either 1 peak or 2 peaks. When you have trisomy, you either get 3 peaks with a ratio of 1:1:1, and also you may have 2 peaks, but there is an imbalance in the peak ratio, either 2:1 or 1:2. So this is a trisomy. By looking at the electrophotogram, you can understand this is a trisomy. Then for sex chromosomes, you see for a normal male you get 1 peak for X, 1 peak for Y, but when for normal male you get only 1 peak, and also for Klinefelter syndrome you get a big imbalance like this. So this is a normal karyotype, and you see 2 peaks for all the chromosomes. This is for chromosome 18. This is for chromosome 21. You see there are either 1 peak or 2 peaks. That is, this is a normal karyotype. But this is an example of Down syndrome. You see, please pay attention. You have 3 peaks here. You have 3 peaks here, chromosome 21. 3 peaks here. And again, you have 2 peaks, but with a ratio of 2:1, and again here 1:2. So this totally confirms that this patient has a trisomy 21, and this also happens for all the chromosomes you are checking. And second, this is the last one. This is the another example of Klinefelter syndrome. In Klinefelter syndrome, actually in normal karyotype, we get 2 peaks, one for X, one for Y. Since this patient has 2 X chromosomes, so X is compared to the Y chromosome. Again, here you see this kind of So, in conclusion, I would like to say that the cytogenetic analysis which is based on ER or Q-matic, they are relatively cheap methods, but it has some disadvantages because it requires longer analysis time, at least several weeks, requires cell culturing, labor intensive, and highly dependent on the experience and skill of the analyst. But fish, it is there are some problems that have been solved in the fish. It has an increased sensitivity, no need of cell harvesting, and hybridization with multiple probes enable the detection of transportation. But the disadvantage is they are still labor intensive, relatively expensive, cannot be automated, and sometimes diffuse signals are obtained because it uses interface problems. And finally, the pure PCR, it is really faster compared to all the methods described here, faster analysis time, and can give you the result or diagnosis within 24 hours. And it is highly reliable and reproducible. It can be automated, and chances of getting false positive and false negative is rare. The only disadvantage of pure PCR is that it cannot detect translocation, but still it can detect partial trisomy and translocation trisomy as well. Thank you very much. Thank you for your attention.
Thank you, Professor Srivatarajanan, to present a very excellent paper on diagnosis of Down syndrome, that is, in case of prenatal diagnosis of aneuploidy. We know molecular biology and also know the cloning of the that is era as Dolly. We know cloning of Dolly, the first revolutionary incident in the history of molecular biology. By adopting this cloning technique, we are also able to clone any person if the law permits. That is, there are various enormous development in various techniques in the field of molecular biology and genetics. From this paper, we are introducing that there is an alternative to karyotyping. From my experience, I want to share with you. It takes that is karyotyping takes a longer time. There is blood sampling method that is subsequently in case of Programmatica, probably karyotyping was successful on hard time. There is also limitation of karyotyping. So in future, this modern technique will be helpful in carrying out the limitations of karyotyping. Thank you again to Professor Akhtar. Now the third paper will be.
I apologize to Mr. Sharif Akhtar Zaman for giving the repeated bell by the billing keeper. Sorry. Actually, I would like as a night things actually 30 minutes. That's the time that the bell is supposed to ring. So we are very much privileged to have our next speaker, Professor Nazim Kobi, Director of Institute of Child and Maternal Health. Done her fellowship in 1988 and done her diploma in advanced obstetrics and gynecology in 1998. And she's involved with very closely involved with the improvement of maternal and neonatal health in our interest. I just you know about it. She's also the Secretary General of Bangladesh Breastfeeding Foundation. She has more than 50 publications to her credit, and now I'd like Nazim Kobi to give her presentation. Respected chairpersons,
dignitaries in the dais, foreign delegate, and learned audience. Assalamu alaikum. And everybody, I am very much thankful to in this dinner session of first national conference. My topic is individual counseling in Down syndrome. What is individual counseling? Individual counseling is a technique of assessing the presence of genetic disorders of an unborn child and making understand the parents about the nature of the disease with its possible management options. This is a happy mother, but we could not make her understand about the Down syndrome. She is very much happy with the Down syndrome baby boy. Now, question may arise during the individual period. What is Down syndrome? Or we discuss how to suspect and confirm during the individual period, problems associated with Down syndrome, treatment options available, chance of Down syndrome in future pregnancies, what impact does Down syndrome have on the society? We all know Down syndrome is the most common genetic condition that results in low intelligence, short body, and delayed development. It occurs in about 1 in 380 pregnancies, and in the United States, every year 6,000 babies born with Down syndrome. The problem is in every unit of the body. The unit of a building is a baby of no. Likewise, the unit of the body is a cell. Then in the nucleus, chromosome carries the genetic information whose number is 46 in each nucleus, but in the Down syndrome is 47 in each cell. This is the 3 chromosome in chromosome number 21. Causes already discussed, but it is 2 different hypotheses. One is genetic gene dose and genetic imbalance. And this chromosome disorder already you have known it is due to autosomal trisomy at 21 chromosome. And the three types: non-reduction, transposition, and mosaicism. What happens in non-reduction? Prior to or at conception, there is a pair of 21st chromosomes in either the sperm or the egg to separate. And embryo develops, the extra chromosome is depicted in every cell of the body, that is trisomy 21. In translocation, about 4% is the translocation. And the total number of chromosomes remains 46, but additional full or partial copy of chromosomes that attaches to another chromosome, usually chromosome 14. And the presence of extra full or partial chromosome from 21 causes the characteristics of the Down syndrome. And mosaicism, which those partially is diagnosed when there is mixture of 2 lines of cells, some containing 46 and some containing 47. What are the main problems? Already mentioned, low intelligence of body, delayed development, stature. But there are some specific characteristics: this upslanting, particular feature, inner efficiency, force, flat nasal piece, open mouth, non higher. And there are other some specific physical characteristics. In head, brachycephaly with flat occiput. In neck, redundant skin on the nape of the neck, and in the abdomen, there may be umbilical hernia. In extremities, in hands are broad and short, clinodactyly, hypocalyptic mini-financial fifth finger, and Syrian piece. In the feet, white central gap between the first and the second row is plantar trees and hyper-extensibility of the joints. Then heart problems is associated with Down syndrome, maybe with ventricular septum defect and commonly endocardial shunt defect. And intestine, there may be renal atresia, and in genitalia, small penis and hypothyroidism, which is responsible for infertility of the male Down syndrome babies. We have also known this figure from first presentation. Older women have an easy chance of having a child with Down syndrome. And this elderly mother, the risk for the Down syndrome baby. Down syndrome done in families is another question. Counseling. Heredity is not a factor in Title 21 non-reproduction and Muller syndrome. But in 1/3 of the cases of Down syndrome resulting from transmission, there is a hereditary component, accounting for about 1% of all cases of Down syndrome. What's the chance of having a second child with Down syndrome? Once a woman has given birth to a baby with trisomy 51, non-reproduction or translocation, it is estimated that our chances of having another baby with trisomy 21 is 1 in 100 up until age 40. And the risk of recurrence of translocation is about 3% if the father is a carrier and 10 to 15% if the mother is the carrier. There is a point to remember. This, I think I should skip off this slide, already discussed. And options of treatment in case of Down syndrome. Supportive treatment always necessary for the Down syndrome, and specific treatment for associated problems, surgery for congenital heart disease. What impact of Down syndrome on the society? Increasingly integrated in the society and community organizations, such as school, healthcare system, workforces, and social and activities. Down syndrome babies are living longer than ever before due to advances in medical technology. In 1910, children with Down syndrome were expected to survive to age 9 or 8. After that, with the discovery of antibiotics, the average survival age increased to 19 or 20. But nowadays, with recent advancements in clinical treatment, most particularly cardiac heart disease, as many as 80% of adults with Down syndrome reach age 60, and many live even longer. Though some communities sometimes, and more Americans are interacting with individuals with Down syndrome, increasing the need for widespread public education and acceptance. In this World Down Syndrome Day, 2006, my friends, my community, the benefits of inclusive environment for today's children and tomorrow's adults. Thanks for listening. Thank you, everybody.
Thank you, Professor Nazneen Kabir, for a very beautiful. I would like to request you if you have any questions. Now, 2 questions per speaker. So you write it down and you can ask him even get the mic.
Now, I want to invite Dr. Rizal Boring Kadul to present his paper on amniocentesis and chronic blood sampling for prenatal diagnosis of Down syndrome. In this aspect, I want to introduce him, Dr. Rizal Boring, first in 1998. And FC. He trained in fetal invasive procedure from Sarvangan Hospital, India. Now he is working as associate professor of obstetrics and gynecology in BSMU. He is the first to report on chronic venous sampling in our country. He had done already more than 650 fetal invasive procedures during this period. And he is an promising physician in the field of prenatal diagnosis of Down syndrome and other chromosomal disorders or genetic disorders. Now, I am requesting him to present his paper.
Respected chairperson of this session, the speakers and the audience, I welcome you to my presentation. I'm Dr. Kajal, working as associate professor in Arts Science Department, BSc. My topic is something new to somebody. I'm describing just the key points in short time. The most common chromosomal abnormality in women is Down syndrome, and there is a lot of problem, nothing to mention. And this is John Langdon Down, who described clearly about the Down syndrome in 1866. And incidents, the birth defect in Southeast Asia, the public health challenge situation analysis 2013 from WHO published that at least 15 babies with Down syndrome born in Bangladesh per day. And mothers have the right to get information. ACOG advises all pregnant women, regardless of their age, should be offered screening for Down syndrome before 20 weeks of pregnancy and have the option of diagnostic testing. And physicians are typically obliged to fully inform our patient about prenatal testing of Down syndrome. In India, advice for prenatal screening of chromosomal abnormality and thalassemia is in the first trimester is mandatory for the physician. It is entirely up to the patient to decide whether or not she wishes to be screened for fetal chromosome abnormality coming from the physician. And see the prenatal screening for Down syndrome and compare the cost. If maternal serum biochemistry 15 to 18 weeks, cost is about 6,000 to 9,000 taka, and rejection rate is 50 to 70%. If fetal natal consistency at 11 to 13 weeks, that is 70 to 80% rejection rate, cost is only 2,000 taka. And fetal anti-maternal serum ACG in the first trimester, 85 to 90% rejection rate, cost is about 8,000 to 11,000 taka. Fetal natal consistency and nasal bone at 11 to 13 weeks, 90% Down syndrome rejection rate, cost is about 2,500 only. And fetal nasal 90 nasal bone maternal serum free beta ACG, and in the first trimester rejection rate is 95%, cost is about 11,500. And what about the genetic comprises fetal nasal bone cancer? The detection rate of Down syndrome is about 95%, and compare the cost only by 2,500 taka. And which one is better? This is your decision. You have the choice and you have the liability to refer a patient who is doing genetic ultrasound and where it is available. This is our duty to give the direction to the patient. And this is the sample copy of genetic ultrasound. See, if the nasal bone is absent, there is 73% chance with trisomy 21, 55% with trisomy 18, 5% with Turner syndrome, and 83% with fragile X syndrome. Only 1% healthy baby would not have nasal bone. So, if you only like to explain the patient that if your baby have the chance of 99% chromosomal anomaly, you can check only nasal bone. This is the example of genetic ultrasound. Know how valuable ultrasound it is. And to confirm the diagnosis, we need fetal cell or cell-free DNA. And this is the process of non-invasive process of modern technique, that is cell-free DNA from maternal blood or biopsy from an embryo, which should be transferred in the ideal cases. You can choose which baby or which embryo is chromosomal normal. You can check before transfer of the embryo. And Non-invasive technique is studying the fetal cell to DNA from maternal blood is still recognized as not a confirmatory test, though it is claimed that it is 98% sensitive, but it is also nowadays still a very good screening test. And you have to confirm by amniocentesis or colon blood sampling. An invasive technique, amniocentesis after 15 weeks and colon blood sampling, that is placental tissue, 11 to 14 weeks. This is the process of diagnosis from amniotic fluid. And this is the size of the fetus at 11 and 15 weeks. See this size to educate your patient that I am 14 weeks or 15 weeks, how much about the size of the baby when there is a question of termination. And some history of amniocentesis and CVS. Amniocentesis was introduced by American obstetrician Brooks and Dennis gastroenterologist Reed in 1956 for fetal sex determination. And after the mid-1970s, amniocentesis were done in a blind method. And Dr. Jean Bang and Allen from Denmark were the first to report amniocentesis done with the guide of an ultrasound, using static ultrasound up to 1972. And folic blood sampling was first performed by Italian biologist Simoni in 1983. Now, it has been used because it provides safety of the fetus and accuracy of the result. We started amniocentesis in 2012 and CBS from 2013. And this is a consent for prenatal diagnosis procedure in English. And this is a sample copy of consent form in Bangla. This is very important to write a consent form in Bangla or easily recognized by our patient. We applied the procedure, that is a chance abdominal procedure under real-time ultrasonography. We applied the two operative techniques like a combination by an obstetrician and an interventional radiologist. For amniocentesis, we chose after 15 weeks, needle size 23G, and for CBS 11 to 14 weeks and needle size 80G. And what about the pregnancy loss during this procedure? This is a great question among us. So I like to explain before real-time ultrasonography, the spontaneous loss of pregnancy was 0.7% versus for amniocentesis 1.7%. So the loss rate during amniocentesis was 1%. And under the real-time ultrasound in the University of California, San Francisco Medical Center, it was amnio and CBS had the same loss rate. Both had loss rate, one is for over last 5 years. About 1 in 769 that not significantly different from that observed in patient who had no procedure. And CDC USA recommends the miscarriages from amniocentesis is 0.25 to 0.5% and CBS from 0.5 to 1%. And less than 10 weeks gestation, there is a 20.2% chance of risk of serious and greater or equal to 10 weeks gestation, 0.07% of limb deficiency or any congenital anomaly of the fetus. So we have applied 11 weeks for CBS for 100% security, and we follow the guideline of Sarbangaram Hospital. And this is our indication and outcome of 355 cases, 155 for CBS and 200 from amnio. I would not like to go in details. And our complication experience in 355 cases, hematoma 7%, bleeding 2%, and bleeding 2%. In conclusion, see the baby. God has created the baby, but mother should decide to know, right to not have a down baby. So not only structural anomalies, but also genetic anomalies should be kept in mind taking care of the pregnant mother. Because genetic defect contributes to increase our neonatal childhood mortality rate, breaking the bones of thousand parents. And transabdominal amniocentesis, clinical sampling under real-time sonography is a useful outdoor procedure
for bring out significant risk to the mother and fetus. We should take care who was born, but we should prevent the birth with genetic defect to make a healthy generation. And we acknowledge fetal medicine department, Sarmangaram Hospital. And at the end, I will show you a video. First we see the gross anatomy of the fetus, and now we are using cheaper only spinal needle by 65 taka. And we clearly see under real-time ultrasound the leg point and the fetus which is continuously moving, and about 20 ml amniotic fluid, that is ml per week, is aspirated. And you should know that there is no need of local anesthesia in this procedure because the needle size is 23 G. It's the amniotic is from twin pregnancy, see different amniotic cavity in different region. But there is no ideal method in case of twin. This is the case of curricular sampling. ভালো প্লেয়ার নাই, খুব ভালো দেখা গেল না ভিডিওটা পর্যন্ত। আপনারা ইউটিউবে কখনো যদি সার্চ দেন এমনিওসেন্টিসিস ইন বাংলাদেশ, তাহলে আমাদের ভিডিওটা দেখতে পাবেন। থ্যাংক ইউ ভেরি মাচ।
Thank you, Dr. Rizal Kajol, for presenting a very informative paper on amniocentesis and chorionic fetus sampling. He is a promising doctor in this field. We wish further success in this field in the near future. Thank you. Now I am requesting Professor Bhavana Dhawan to conclude this session.
We are sorry we couldn't accommodate the questions because I'm constantly an hour late. So I would like to conclude here by thanking all the presenters for their excellent presentation, and we have immensely benefited. So now I invite you at the second. Thank you.
Madam, I would like to request you please hand over the crest to the honorable speaker. I would like to request the chairperson of session 1, Professor Farhana Dhawan Madam and Professor Mohindranath Rai sir, to hand over the crest to the honorable speaker. Professor Firoza Nair. Professor Nazim Kobi.
Dr. Rizal Kadir. Our another speaker, Dr. Sharif Akhtar Jamal. Thank you. Today, we have 6 sessions in our conference. Now we are going to our next session, that is our second session. We have 2 chairpersons and 3 sessions. As our honorable chairpersons, we have Professor Saida Afroza, Professor and Head of Department of Trinity College Hospital. And we have Professor Ruhul Abi, Professor of Pediatric Pulmonology, and former President of sorry, due to some unavailable circumstances, he is not here, so he joined us later. But then, so first speaker will be Dr. Narayan Saha. He is the Associate Professor of Pediatric Neurology, National Institute of Neuroscience, Dhaka, and he is the fellow of this Mandir Fund of Physician and Surgeon. He has done his FCPS from BCPS and he has achieved his fellowship in pediatric neurology from All India Institute, and he is a contributor
as chapter author of 3 pediatric books international published. Now I invite Dr. Narayan Shah to present his paper in front of us. Thank you. And I request the speaker to keep his time 10 minutes.
For me to be present in this auspicious gathering, and I am thankful to the organizer for giving me the opportunity to speak about the neurological manifestations of Down syndrome. Actually, it's a recognition. All of you know everything about the Down syndrome. Just it's a recognition of one knowledge about the different manifestations of neurological manifestations of the Down syndrome. So the running objective of my presentation would be to discuss the common neurological manifestations and to identify their particular neurological disorders. Actually, all of you know what are the neurological manifestations of the Down syndrome. Just to recapitulate, one of the presentations could be developmental disabilities in the form of either motor delay or they can presenting as cognitive, hearing, speech and learning problems, or otherwise they can have some neuropsychiatric manifestations, attention deficit hyperactivity disorder, then autism, depression, oppositional and disruptive behaviors. In the research, it is evident that the prevalence of autism and ADHD is highly prevalent among the Down children. The other neurological manifestations are mental retardation with an average IQ of 25 to 50, and the other neurological manifestations could be Alzheimer's disease, Hashimoto's encephalopathy, and brain tumor. But I'd like to draw your attention for some of the treatable diseases. These are obstructive sleep apnea, which occurs in about 50 to 70% of the cases, but there are usually cases and different types of epilepsy. And last but not least, to draw your attention on two things about the Atlantic subrestrictions and different manifestations of stroke in children with Down syndrome. Actually, because of this, because of the muscle tone is low, because of that, and skeletal changes that lead to the obstructions of their airways in children with adults with Down syndrome. So they are very much at better risk of obstructive sleep apnea. If you could identify at an earlier stage, there is a preventive treatment for obstructive sleep apnea in this group of children. Otherwise, they can present as snoring, restlessness during sleep, or they can somnolence. All of these are treatable things. That's why I like to draw your attention regarding on the important manifestations of Down syndrome. What is about the hearing loss? There are three types of hearing loss could be happening in case of Down syndrome. That could be conductive type of hearing loss, or other that could be other sensory loss or this type. And can develop at any time. And the recommendation by the American Academy of Pediatrics to have a hearing assessment at birth and then at least 6 months to 4 years and thereafter every, because it has been seen on longitudinal studies, the children with Down syndrome may develop hearing loss in their subsequent ages, though they are not present in early infancy or childhood. So what is about epilepsy? Just like other common populations, the prevalence of epilepsy is much high in children with Down syndrome than with compared to their normal rating. There is a binomial presentation of epilepsy in this group of children. One is around the infancy, another is the late adulthood or late adulthood or late childhood or early adulthood. And in the young group, the two types of epilepsies are more common. One is the infantile spasm and second is the GPCS. But in the older group of children, the simple or complex partial seizure as well as generalized tonic-clonic seizure could happen. The line of treatment of this kind of epilepsy is like that of the other children, but one should keep in our mind the treatment resistance of infantile spasm in children with Down syndrome. They are very much difficult to treat or control infantile spasm in children with compared to the normal other children. So what is about the atlantic distribution or sublution? I like to draw your attention in this meteorological meditation because it is if you could make awareness of our colleagues, then it is very much important to make an awareness of this neurological meditation because that can be identified clinically and treatment outcome is good, provided if you got diagnosed at a appropriate time in appropriate therapy. So actually what happens in case of atlantic sublution? All of you know there is a hypotonia in Down syndrome. So there is a choice of. So what happens in C1 and C2 particular, there is a pivot. So because of the laxity of the joint, laxity of the ligament, it tends to the axis, usually goes backwards from the anterior arch of the atlas, which I will show you in the axis view. So there is a chance it may be subducted in it and subsequently they may compress the spinal cord. And if they press the spinal cord, what happens is just lapping, or they may have radicular pain in the form of radiculopathy, or they can present as spastic quadriplegia. One thing one should keep in mind, the prevalence of atlantic axial subluxation is high, up to 10 to 20%, but one is good thing for only 1 to 2% becomes symptomatic, that is they have compressive myopathy. So what are the presentations? The easy fatigability, neck pain, or there will be radiculopathy, neck pain or torticollis, and difficulty walking or spastic quadriplegia. So when to suspect and how to screen and how to treat. Any child who have a difficulty in walking or neck pain or torticollis, in and around 3 to 5 years, one should suspect the child may have atlantic subluxation. In this case, one should go for lateral axis of the cervical spine in flexion extension view, where the distance between the anterior arch of the atlas and the joints of the axis is normally 5 mm. If it is more beyond 5 mm, one should suspect the child may have atlantic subluxation. So, radiologically, we can see the child has atlantic, but once they have atlantic subluxation, in that case, one should examine clinically whether the child has quadriplegia or any other signs of spinal cord compression as upper or in the upper limb. So, plain radiograph inspection and extension, the expected distance between the anterior arch of the C1, that is the atlas and axis, normally 5 mm in children. If it is beyond 5 mm, one should be sure that the child may have atlantic subluxation, may present with compressive myopathy. So, if you look at this X-ray, on the top left side, it is the anterior arch of the atlas, and on the right, that is the axis. So normally the distance between these, we are going to equate this is the normal distance. So this is the anterior arch of the atlas, and this is the joints of the axis. So normally the distance is around 5 mm. If the distance is more than 5 mm, so you assume that the child has subluxation. That means the joints usually present this spinal cord posterior. So there is a chance of compressive myopathy that can present as spastic quadriplegia. So that is the preoperative view of atlantic dislocations having spinal cord compression. So how to prevent dislocation? As I have already told, there may be asymptomatic cases of atlantic subluxation, there may be symptomatic cases of atlantic subluxation. If your child has an atlantic subluxation, there is very much risk of dislocation. So in that case, they have to maintain a lifestyle so that there is no hyperextension of the neck in the form of rotation or swimming or thinking. In this way, you can prevent the dislocation. So stroke in the another common children Down syndrome is stroke. They can present one is that is they may have underheartedness, and second thing is the cerebral idiopathy, that is they are presenting as Moyamoya syndrome. So all of you know actually Moyamoya syndrome is an idiopathic vasculopathy where there is progressive occlusions of the internal carotid artery at its bifurcation. And if a child presents with stroke beyond 5 years to age, clinically echo cannot identify any cardiac lesions. In that case, one must suspect the child may have Moyamer syndrome. And if you suspect Moyamer syndrome, they will usually the impact will not be in the territory of the vascular territory. And in that case, you should ask for MRI, and they will give you the diagnostic criteria of Moyamer syndrome. That will I will show you the next photograph. So that is the classical MRFI of the Moyamer syndrome. This is the path of smoke appearance. So it is the cycle of collisions where the internal carotid artery bifurcates into anterior and medial cerebral artery. As there is an occlusion in this area, so there is a chance of development of full artery. And that will give the appearance of path of smoke appearance. It's a company language. It is called path of smoke appearance. That is Moya means Moya, that is you are going here in the MRI findings of Moya disease. And one should keep in mind is a 100% critical thing. You just need an anastomotic surgery, or now it is possible in our country. So thank you all for patience here.
Thank you, Dr. Nara, for presentation. We have just enjoyed a very nice life, Dr. Nara. You see, even though the Down syndrome babies have different characteristic features, they might have serious neurological problems which might be ignored. So we have to screen them for having those problems, and we need to correct those as early as possible. Now our next speaker is Dr. Fauziya Mohsin, who is the Associate Professor of Pediatric Endocrinology, Barden General Hospital. She has done her FCPS from BCPS and fellowship in Pediatric Endocrinology from Australia. And she is the founder, Secretary General of Pediatric Endocrine Society Bangladesh. And she has 3 publications as co-authors in books in the childhood diabetes. And she has got award, that is Young Investigators Award by International Society of Pediatric and Adolescent Diabetes. So she is a very brilliant doctor, and I would now request her to present her paper. Dr. Fauziya Mohsin.
Thank you, Chairperson, for your kind words. Respected seniors and beloved audience, Assalamu alaikum. First of all, I would like to thank the organizer for giving me the opportunity to speak here. We all know that Down syndrome is the most common chromosomal disorder with an incidence of 1 in 700 live births. It is the most common cause of mental retardation and associated with short stature and congenital anomaly, and there is higher incidence of endocrine disorders than in general population. Among the endocrine disorders, hypothyroidism is the commonest. We can also find diabetes mellitus, both type 1 and type 2, obesity, hypogonadism, and hyperthyroidism in children with Down syndrome. Autoimmune disorder is also common in children with Down syndrome. Among them, endocrine disorders I have already mentioned. Addison's disease and hypoparathyroidism can also be found. And among the non-endocrine disorders, celiac disease, alopecia, vitiligo, and other autoimmune disorders are common. So when we find this autoimmune disorder, we should also keep in mind of the possibility of other endocrine disorder and other autoimmune disorder in these children. As I mentioned before, thyroid disorder is the most common endocrine abnormality in Down syndrome. The spectrum of thyroid abnormalities include congenital hypothyroidism, compensated hypothyroidism, autoimmune thyroiditis, acute hypothyroidism, and hyperthyroidism or Graves' disease. This is the slide of the problem. We have seen in our garden agency endocrine OPD in children with Down syndrome. As we can see that hypothyroidism is very common. We have found in about more than 50% patients we have seen hypothyroidism. Congenital heart disease is also very common. Then diabetes, obesity, micropenis, precocious puberty, anticellular disease, adrenal insufficiency, hypocalcemia, alopecia, and hyperthyroidism are also seen. And in our children with Down syndrome, 21 children of 38 patients with Down syndrome were found to have hypothyroidism. Among them, 48% had congenital hypothyroidism, 38% had subclinical or compensated hypothyroidism, which is very common in children with Down syndrome, and 14% had acquired hypothyroidism. And this is another study done in Dhaka Hospital where hypothyroidism was detected in 12.5% of children with Down syndrome in 32 patients. And among these 32 patients, 4 patients had hypothyroidism, 2 cases with overt hypothyroidism, and 2 cases with subclinical or compensated hypothyroidism. Now I will discuss some interesting cases presented to our department. Our first case is a 4-year-old female child presenting with cyclic or vaginal bleeding for 1 year, inability to walk without support, and deviate speech and constipation. She was a known case of Down syndrome. On examination, she had typical features of paler, dry, and rough skin. This is umbilical hernia. Her breast stage was 2. And on investigation, we can see that she had low hemoglobin, low FT4, very high TSH, very high FSH. Estrogen was also very high, and anti-thyroid and antibodies were positive. Her bone age was much delayed. Ultrasonogram showed bulky uterus, enlarged ovaries containing multiple small cysts. So our diagnosis was Down syndrome with hypothyroidism with precocious puberty due to untreated hypothyroidism with anemia. Here we can see that as the diagnosis was delayed very much, so she had complication of untreated hypothyroidism, that is precocious puberty. We managed the child with thyroxine, iron, folic acid, and vitamin. Neurological and hearing assessment was also done. Our second case is a 4-year and 6-month-old female child presenting with polyuria and polydipsia for 1 month, loss of weight for 15 days, fever for 5 days, vomiting and altered consciousness for 1 day. She was Down syndrome examination. She had typical features of Down syndrome. She was severely dehydrated, had rapid and weak respiration. Her random blood sugar was very high, urine for positive for acetone, and she had metabolic acidosis. Her thyroid function was in the lower normal range, and TSH was high. So our final diagnosis was Down syndrome with type 1 diabetes with diabetic ketoacidosis with subclinical hypothyroidism. Again, we can see that our patient presented with acute complication of diabetic ketoacidosis. We initially treated her for diabetic ketoacidosis, then subcutaneous insulin was started with tablet thyroxine for treatment of subclinical hypothyroidism. Our third case is a 12-year-old girl presenting with restlessness and weight loss for 1 month. She was a known case of Down syndrome with developmental delay and back. On exam, was irritable, restless, had moist palm, microptosis per minute. She had high FT4 and FT3, suppressed TSH, antithyroid peroxidase antibody was positive. Our final diagnosis was Down syndrome with hyperthyroidism. We treated her with tablet propranolol and tablet carbimazole. Now, few words on congenital hypothyroidism. As I have mentioned, it is 28 times more common than general population with an incidence of 1%. In various studies, mild hypothyroid state in newborns with Down syndrome has been reported, and there has been report of improvement in their outcome in treatment of these children with even mild hypothyroidism. So I won't go into the detail of clinical features. We all know about this. But the fact is that often the clinical feature of Down syndrome phenotype and clinical feature of hypothyroidism can overlap. So there may be delay in diagnosis. And it is very important for early detection by newborn screening. And treatment is safe. In follow-up, we have to monitor the dose of thyroxine, and GSH should be maintained in the age-specific normal range, and T4 or VT should be maintained in the other. And this is a study which shows relation to age and of thyroid dysfunction. In this longitudinal study among 84 patients, we can see that patients develop 30 patients develop hypothyroidism later, and half of these patients acquired the condition before the age of 8 years, and thyroid antibodies were mostly found in patients who develop hypothyroidism after the age of 8 years. So guideline for screening of hypothyroidism is by newborn screening, then at 6 months of age and at 12 months of age, and then yearly thereafter. Hypothyroidism prevalence is 54%, and if the frequency of hypothyroidism increases with increasing age of the individual with Down syndrome. I won't go into the signs, symptoms, and treatment. Diabetic mellitus prevalence is 4 to 8 times higher in people with Down syndrome. Both type 1 and type 2 diabetes has been reported, and there is an increased risk of presenting with complications as we have seen before. The symptoms, the typical symptom and atypical symptom also we are aware of this. And the criteria for diagnosis is fasting blood glucose 7 millimole or more, and random blood glucose 11 millimole per liter or more. Management is the same for type 1 diabetes, insulin; for type 2 diabetes, weight management, oral drug or insulin, along with diet, exercise, education, monitoring. In up to 30 to 50% of children of Down syndrome have obesity, and mechanisms associated are hypothyroidism, decreased basal metabolic rate, increased leptin, poor mastication, and behavioral tendencies. Prevention can be done by regular monitoring of height, weight, and BMI at least yearly, anticipatory guidance on diet and healthy lifestyle, and management is by looking and treating for complications of obesity like diabetes, exercise and nutrition-based intervention typically tailored. Short stature in Down syndrome. Growth retardation and short stature are cardinal sign of Down syndrome. Growth velocity is markedly reduced during the normal period of accelerated growth. Measurement of height and weight should be plotted on growth charts specifically designed for children with Down syndrome. In a study among 15 children with Down syndrome, growth hormone treatment resulted in normal growth velocity, and it improved the growth velocity, but routine dose of growth hormone in children with Down syndrome is not recommended. Now, further function in Down syndrome, the reported abnormality in gender hypogonadism, with delay in abnormality in boys, ambiguous genitalia, undescended testes, micropenis, small testes, etc. Fertility is present in 30 to 50% of females with Down syndrome. Fertility is significantly reduced in men due to defective spermatogenesis. Now, conclusion. Individuals with Down syndrome have a higher incidence of endocrine problems than in general population. Among the endocrine problems, hypothyroidism is common. Clinical feature of Down syndrome and these endocrine problems can overlap and can lead to delay or difficulty in diagnosis. there is an increase in frequency of thyroid disorder with increasing age of the individual. Therefore, annual screening for hypothyroidism after infancy in Down syndrome is recommended. Awareness about this endocrine disorder, screening, early diagnosis and management of this problem in children with Down syndrome is very important. Thank you all for your patient hearing.
Thank you, Dr. Fauziya Mohsin. So now, dear audience, we do not have our yet, so I would request you to ask questions. 2 questions for each speaker. If you want, you can ask questions. Do you have any questions? First speaker, Madam. Is there any question for first speaker? No question. For second speaker? Okay, probably there is no question. So, dear audience, our money except one of our participants, all of us can understand Bengali. And for the mothers and the parents and the children, I'd like to speak in Bengali. Few words about our station and about the Down syndrome. আমরা দুটো পেপার শুনলাম, খুবই ইন্টারেস্টিং এবং জানলাম যে আগের পেপারগুলোতে আমরা জেনেছি যে ডিফারেন্ট ফিচার্স অফ ডাউন সিনড্রোম কিভাবে ডায়াগনোসিস করা যায়। এখন আমরা দেখেছি যে ডাউন সিনড্রোম Dr. Nanam Shah has expressed the neurological problems of Down syndrome, যেটা আমরা সহজে বুঝতে পারবো না, তবে যদি তাদেরকে স্ক্রিনিং করায় এবং তাদেরকে ডাক্তারের কাছে নিয়ে যে চেক আপ করায় তাহলে কিন্তু এটা আইডেন্টিফাই করা সম্ভব। আদারওয়াইজ ডাউন সিনড্রোম যেগুলোতে এমনি একটু নরম থাকে, একটু নাজুক থাকে, তাহলে তো ভাবতে পারেন যে ওটা এমনি কিছু এরকম। কিন্তু we have to find out whether the child has got any neurological problem or not. এটা দেখা দরকার। Dr. Fauziya Mohsin nicely shown about the endocrine disorders, especially she has focused on the hypothyroidism, especially this is very common, and the congenital heart disease is also common, but she has focused mainly the endocrine disorders, the hypothyroidism and diabetes mellitus, and she has spoken on the endocrine disorders in children with Down syndrome. Hypothyroidism, then diabetes mellitus and short stature. So আমার মনে হয় যে ডাউন সিনড্রোম বাচ্চাদের কিন্তু অনেক পোটেনশিয়ালিটি থাকে, আন্ডারলাইন পোটেনশিয়ালিটি, হিডেন পোটেনশিয়ালিটি, দোজ we can uncover those, কিন্তু যদি তাদের ইয়ে থাকে, হাইপোথাইরয়েডিজম থাকে, তাহলে কিন্তু সেটা সম্ভব না। সেজন্য প্যারেন্টসদের প্রতি আমার ইয়ে থাকলো, আমার পরামর্শ যে ভবিষ্যতে যদি তার ছোট বাচ্চা থাকে বা যাদের বাচ্চা এখন তাদের থাইরয়েড ফাংশন স্ক্রিনিং করা, ডিটেকশন করা ড্যামেজ হবে না। তাদের কিন্তু আমরা এর মধ্যে দেখছি বাচ্চারা খুব সুন্দর গান করে, নাচ করে, তারপরে অনেকে সেলাই করতে পারে, অনেকে আবার ছবি আঁকে, খুবই সুন্দর ছবি আঁকতে পারে। এগুলো অনেক অনেক প্রতিভা তাদের আছে, যেগুলো ওদেরকে আমরা সাহায্য করলে, তাদেরকে এনকারেজ করি, তাহলে আমরা এই প্রতিভাগুলো বিকশিত করতে পারবো। এবং আমি মনে করি যে ডাউন সিনড্রোমের বাচ্চা আমাদের ভবিষ্যতে কিন্তু ওদেরকে মানে আমরা আন্ডারলাইন করবো না, তাদেরকে আরো এনকারেজ করবো, এবং ওরা কিন্তু বাচ্চা আছে। সুতরাং আমাদের হতাশা কিছু নেই, প্যারেন্টদের তাদেরকে আমরা ঠিকই একটা সমাজের অন্য বাচ্চাদের মতোই একজন সমাজের শিশু হিসাবে তাদের পাশাপাশি আমরা তাদেরকে গড়ে তুলবো, এই কথা আমি ব্যক্ত করছি। আমি I would like Director for providing us this venue and for this conference, and my other colleagues for helping the team of the conference, the organizers, for its success. So with these few words, I would like to thank both of our speakers. Thank you and congratulate you both for your excellent presentations. And I would like to thank all the audience for your precious hearing. Thank you very much. Assalamu alaikum.
I'd like to request our honorable chairperson, Professor Dr. Madam, to notify the press to the respected speakers, Dr. Narayan Chandra and Dr. Fawzia Mohsin. Respected audience, we are going to start our third session, and this session will be chaired by Professor Dr. is receiving the crest from Professor Sarita Apollo Madam. Third session will be chaired by Professor Shahida Akhtar, Professor of Neurology, Barden General Hospital and Israeli Medical College, Dr. Sumit Rai, Associate Professor in Neurology, Sciences of Tirumala Medical College and Hospital. Speakers for these sessions are Marie Leonel G. Morris, she is from Brazil, Associate Professor of Dentistry, Associate Professor of Radiology, School of Dentistry, Sao Paulo State University of Brazil. Next speaker is Dr. Masuda Khatun and Dr. A.N. Chandra Rahman.
Assalamu alaikum and very good morning. I'm Dr. Shahida from Barden Hospital and presenting the first session of today's conference. I will present the first session of today's conference. There will be three presenters. One is from Brazil. Yes, Dr. Marie Leonel G. Morris. I'm very happy to see her because she's from Brazil and I had been there for a while, for visit. She is from the Department of Diagnosis and Surgery, area of Radiology, School of Dentistry of campus, Santa Maria, Brazil. So she will say something on dental and analysis of dentistry. I request her to present her.
Hi, good morning everybody. I'd like to first thank you Dr. Amhan and Dr. Magenta for the opportunity to be here talking the first Bangladesh Down Syndrome Conference. As you said, I'm from Brazil. This is my city, São José dos Campos, São Paulo. And this is my university, called São Paulo State University, Institute of Science and Technology. I'm a professor from the School of Dentistry. This is our students. And I'm going to talk something about the dental anomalies in patients with Down syndrome. Down syndrome individuals present several congenital systemic clinical alterations. They also present oral alterations and dental anomalies. The incidence of Down syndrome in Brazil is around 200,000 people, and in the world, over 6 million. Regarding to craniofacial condition, we have brachycephaly, when we have the small end of hands and short face, small mandible and maxilla, and flattened profile. When you think about oral alterations, they have low prevalence of caries because they have immune protection caused by elevated salivary ethnosis, specific Ig concentration. They also have high prevalence of response rather than to a specific periodontal pathology. Here we can see a case of periodontal disease. The tongue has microglossia and its fissure hypotonic and protrudes. You can see in the first one, the fissure tongue and the second tongue protrudes. They also present angular caries that are caused by candida albicans that occurs, and one or both angles of mouth. Dental malocclusion is very, very common. 92% of our patients present malocclusion, and the most common is class 3 malocclusion. It's a situation when we have advanced mandible and 3% of the patients, and the improper children, 60%. 45% present anterior open bite and mouth breathing, occurs in 96%. Bruxism occurs in 45% of our individuals, and there is a situation when there is a possible clenching or grinding of it or combination of both during sleep with a stronger mandibular joint or 24% of endoscopic. Repeat has complete mineralization with a great variation in the eruption pattern, generally delayed in both primary and permanent phase, and there is a similarity in the secrecy and symmetry. So the purpose of my research was to evaluate dental anomalies in patients with Down syndrome in my university. We evaluate the 49 panoramic X-ray of syndrome patients aged between 3 to 33 years old, being 20 males and 27 females. And all the exams had the permission of parents or guardians. To evaluate dental anomalies, we use the International Classification of Disease that considers shape, number, and tooth eruption. So our results showed a lot of types of dental anomalies, and the most common was parodontitis that occurs in 85%. What's parodontitis? It's a situation when the teeth present elongated pulp chamber and upward placement in bifurcated or trifurcated roots. But the problem, no treatment for this anomaly. just see through X, we just see X by the X-ray examination. And the other interesting result is that when we have in the group of molars, we also find molars too in the same patient. So when we compare with the literature, Albert and Aronoff had found 66%, and we had found in 42 or 49 patients. So it's very, very common. Another dental anomaly is anodontia, and it occurs in 53%. And that's the situation when there is the presence of the tibial tooth and the absence of the permanent tooth germination seen through radiographic examination. What's the normal condition? We have the deciduous tooth and the subsequent permanent germination. But when we don't have the germination, we consider anodontia, and we can see just through X-ray examination. Clinically, we can keep the deciduous tooth normally. Here is an example of a patient who presents anodontia in premolar. Doesn't have any premolars. And here another example, in a patient, we can see a clinical situation, and he doesn't have 6 teeth. He has an anodontia in 6 teeth. Consider the region. We can see in a neglected central incisor 11%, lateral incisor 80%, and premolar is the most common, 31%. And the maxillary teeth, we find lateral incisor 20%, canine 13%, and premolars 60%. And when we compare with the literature, Andrews and Burton have found 45%, Boeing 30%, Design 50%, and Kumazaka 63%. So it's a very common dental anomaly. Another one is point teeth. And when we have it with a cone shape, we can see the photograph shows cone shape. It's easy to treat. With this, in a situation where with a strong region, we have the radiograph and the clinical situation. Microdontia, we have found 2%, is smaller than normal size. And the last one, the labial eruption, and we have found. And the other interesting result is that many patients more than associated. So, 42% present 2 associated anomalies, and 80% 3 associated anomalies, and 4% 4 associated anomalies. So this is an example of a patient who presents 4 associated anomalies. So he has parodontous, anodontia, conic teeth, and retained teeth in the same patient. A second example, I have another patient who presents 2 associated anomalies, anodontia and retained tooth. So, we can conclude that dental anomalies in patients with Down syndrome is very, very pronounced. And of course, it's 95% we have 95% of incidents. And during their growth, the majority of these patients present at least one kind of dental anomaly, and it's common to have more than one associated anomaly. This outcome reinforces that dental care should be directed to prevent I like to present and also problems that reach this effect. This is my family. These are some patients, and thank you very much.
Thank you, Professor Lily. The second question.
Thank you, Professor from Brazil. Council from Dhaka Medical College and Associate Professor of Dermatology. I request
Respected chairperson and the foreign speaker and my dear senior colleagues and junior colleagues and my beloved Down syndrome baby and the baby also. I welcome you all in each. First of all, I must thank the organizer, Dr. Abulga, who gave me the chance to speak in front of you in this hospital. So, Assalamualaikum, and today I am going to present my presentation about the sleep infestation of Down syndrome, first described by John Longdon in 1865. We all know about the Down syndrome, the physical features, and the multi-system anomaly, some of which are dermatology. Down syndrome have high rates of infection and autoimmune disorder. The immunological disturbances in Down syndrome are as follows. High IgG, they have high IgG and low IgM level and reduced total lymphocyte count. They have also high CD8 count and low CD4 count and also reduced lymphocyte process. This could be indicated in the higher TPS infestation. Dermatological diseases associated with immunological alterations are atopic dermatitis, seborrheic dermatitis, alopecia areata, vitiligo, and multiple infections. Some other diseases which are not associated with immunological alterations are anatoderma, media like calcinosis cutis, acanthosis nigricans, pneummomas, elastosis purpuralis actiginosa, leukemia cutis, acrocyanosis, cutis marmorata, and captodermatosis. Now, the atopic dermatitis, which is very common. Here, patient presents to us with very dry skin, pruritus, ligatous lesions, and chronic recurrent spores. It's a genetic defect in epidermal barrier system of the skin. It affects more than 50% of Down syndrome. Diagnosis of atopic dermatitis is done by some major and minor criteria, which is popularly known as Hanifield and Lakshya criteria. Then the seborrheic dermatitis is also a common presentation or disease and chronic disease of unknown etiology, characterized by scaly and redness of the area of highest serous blood concentration. Melasthenia purpura organism is also responsible for this condition. And the alopecia areata, recurrent non-spreading type of patchy alopecia, patchy hair loss. It causes tremendous emotional and psychosocial distress, relatively determined and immune-mediated disorder of hair follicle. Here, the picture shows the patchy alopecia, and with the chronic course, it becomes total alopecia totalis, or even it may go to alopecia irreversible. Now, the vitiligo. This is a hypopigmented disorder of the skin. It's also caused by autoimmune, genetic, and oxidative stress, neural, and viral cause. Here, the melanocytes are lost, so there is a petty depigmentation of the skin and hair. It also associated with Addison's disease, hyperthyroidism, and pernicious anemia. infection, there are multiple infections like bacterial in the form of folliculitis, fungal, abscess, secondary infrared growth. Staphylococcus is the main cause of this infection. There is also fungal infection, onychomycosis, Pinnapedes, and scabies. It's also caused by the Saccharomyces tabiae. The severe itching or at night, usually friendly contact is positive. The babies of Down syndrome are tends to develop the crusted scabies, which is also called the Norwegian scabies. Here are the pictures of this infection. The typical sites, the scabies, cascade scabies, and infrared growth, and many of the infections of the skin as well as Down syndrome. And there is some other dermatological infection. Anicoderma. This is a benign dermatosis caused by loss of mid-dermal elastic tissue. Here, the pouch-like annihilation of the flaccid skin may be due to recurrent inflammatory process. Media-like calcific cutis. Here, the microretinal whitish, acral, and calcified lesions on the acral part of the body. It thought that there is high concentration of calcium in the soil of Down syndrome patient. So it causes the media-like calcific cutis. When the acanthosis nigricans, hyperpigmented, thickened, and velvety skin on the various sides of the forearm increases. It's also related to obesity and endocrine disorder and excessive growth hormone. Lesbisis purpuris subdiginosa, pruritic pepple, keratotic flag in annular, axiform, or subdigenous pattern. Focal lesbisis of lummis and transemidermal illumination of abnormal elastic fiber. And others, lesions are oral, fissure tongue, geographical tongue, macroglosia, and juvenile periorbital twist. And there is also cutis marmorata acrocyanosis. These are the transient reticulated cluster pattern in the skin of the extremity of the baby. And cutis marmorata acrocyanosis are likely more common in Down syndrome. This is due to poor bacterial circulation, and it means that there is an increased incidence of congenital heart disease. And keratodermatosis is usually found in the palm and sole. This is a beautiful picture of the bishop tongue and geographical tongue and the cutis marmorata and the hyperkeratosis of the palm and sole. So, thank you all for patience hearing.
Thank you, Dr. Masuda. Nice in Down syndrome. Next presenter. जिनका क्या आपका डाउन सिंड्रोम देखिए डॉक्टर नौशद कैसा रोमन
I think the speaker is absent. So let's have paper. The speaker is absent. So thank you very presenters. They have brought two very short in management of Down syndrome babies because we know they start using teeth from very early time, from 6 months to 1 year. And forming teeth is a problem for constant problem. Basically, we have to take food, we have to digest it. We start by chewing. So if the forming teeth is very cumbersome. May I say something because there are mothers who understand Bangla. I want to say in Bangla. What do you want to say? In my language, I want to say in my language. Okay? What you think? এখানে যারা ডাউন সিনড্রোমের মায়েরা আছেন তাদের প্রতি শ্রদ্ধা জানিয়ে আমি যে প্রেজেন্টার বিদেশ থেকে ওনার কথা ওনার যে পেপারটা প্রেজেন্ট করলেন যে দাঁতের আসলে তো চিবাতে আরম্ভ করে, এখানে কিন্তু তার হজম প্রসেসটা শুরু হয়। মুখের আমাদের লালা গ্রন্থিতে যে এনজাইম আছে সেটা দিয়ে তার হজম প্রসেসটা শুরু হয়। একটা শিশু যদি দাঁতের সমস্যা থাকে, উনি কতগুলো সমস্যা নিয়ে আসছে, দাঁত উঠে না কিংবা উঠে ভেঙে যাচ্ছে, ভিতরের স্ট্রাকচার তার গঠনটা সঠিক না, তারপরে আঁকা বাঁকা উঠে, তো জীবনের যদি সমস্যা থাকে তার সমস্যাটা প্রতিদিনের প্রতি ঘন্টা উনি এত ভালো একটা দিক থেকে নিয়ে আসছেন, আমরা অনেক সময় লক্ষ্য করি না, কিন্তু যার দাঁতের সমস্যা হয় সেটা যে কত কষ্ট, এবং সে যদি ঠিক করতে না পারে, ঠিক মতো হজম করতে না পারে, তাহলে তার স্বাস্থ্য কত ক্ষতি হবে। তো আমি অনেক মেনলি থ্যাঙ্কস from our side, Dr. Leonelli from Brazil. She has come from South America. I had been there, South America. South America থেকে Leonelli চলে উনি অনেক আমাদেরকে শিখিয়েছেন। তো আমি অনুরোধ করবো যে আপনারা আপনাদের শিশুর দাঁতটা অবশ্যই পরীক্ষা করাবেন, যা কিছু করার চিকিৎসা হলে তাদের অনেক ভালো হবে। আমাদের দ্বিতীয় স্কিনের অনেকগুলো সমস্যার কথা আমি তুলে নিয়েছি। সরকার রিলেটেড ওদের যে রোগ প্রতিরোধ ক্ষমতা তাদের কম, এই রোগ প্রতিরোধ ক্ষমতা রিলেশনাল কতগুলো ছয়টা ডিজিজ দিয়েছে, এই নয়টা ডিজিজ দিয়েছে স্কিনের যেটা নাকি ইমিউনিটির সঙ্গে রিলেটেড না। তার মানে অন্যান্য শিশুদের ক্ষেত্রে এদের স্কিনের প্রবলেমও অনেক বেশি হচ্ছে, তাহলে এদের কষ্ট অনেক বেশি, এদেরকে একটু স্পেশাল কেয়ার দিতে হবে। সব দিকে মধ্যে অনেকগুলো দিক আছে শিশু, কিন্তু দাঁত এবং স্কিন এই দুটো অনেক বেশি অ্যাটেনশন দরকার। আমি অনেক মেনি থ্যাঙ্কস ফ্রম আউটসাইড টু both the speakers. So I will request thank you, madam, for your delivery speech.
Thank you, both the speakers.
Thank you. Thank you very much, our honorable chairpersons, Professor Shahin Akhtar and Dr. Now I would like to request our